Important clinics. Evesham is based on the hospital site, and Malvern is just behind Malvern Hospital. They're both having some works done in the early new year to have their surgery cabinetry upgraded to bring it in line with the other surgeries. And we have, as you can see, the chairs there. We have special dental chairs in all of our clinics now, which are the knee break chairs, and they allow people to be able to access them a lot easier because they haven't got to kind of get into it with the legs raised. The legs raised once they're sat down. So again, it helps our patients who do struggle to access dental clinics to be able to use a dental chair.
Thanks, Rachel. So talk a little bit about paediatric dentistry. I think fairly self-evident that it's a specialty of dentistry that looks after children and young people from 0 to 16, but particularly focuses on those that have extensive oral disease and those that have intellectual, mental, physical, social, psychological and or emotional factors or disabilities associated with that as well. So additional challenges in terms of barriers to accessing care generally, and we know statistically poor oral health as a starting point as well. It also covers those with developmental disorders of their mouth and their teeth, and those that are too anxious or too young to accept routine dental treatment. Service also covers those with complex dental trauma, and significant proportion of that service is delivered using inhalation sedation with nitrous oxide. We've done some fantastic audit work in the last few years. One of our colleagues has looked at our success rates, and it's really shown to reduce the need for general anaesthetic by undergoing that route, and that's something that we're able to carry out in all of our clinic sites. But we do also have access to carry out dental extractions under general anaesthetic. So this is a service that we run in partnership with the Acute Trust at Kidderminster Treatment Centre, and we have between 2 and 3 lists per month treating children who unfortunately require having their teeth removed under general anaesthetic. We also did some interesting audit work, so we took part in the national audit last year, and that looked at the environmental impact of using nitrous oxide in dentistry. And so we're excited to repeat that audit again this year. So really focusing on how we can minimise the environmental impact of nitrous oxide, which is a known greenhouse gas. Special care dentistry,
they're both having
my area of interest, and I've been on the specialist list for special care dentistry for nearly 10 years now. It is the branch of dentistry that looks to improve oral health for people with physical, sensory, intellectual, mental, medical, emotional and social impairment or disability. So that there isn't really a distinction per se between paediatric and special care dentistry. We treat adults and young people under inhalation sedation as we do with children, but in the older cohort we do also have additional options of using intravenous midazolam and transmucosal, so it's intranasal midazolam, again in many of our clinic settings. So at the moment that is undertaken at Orchard Place Clinic in Redditch and Moore Street Clinic in Worcester, but we would really hope to develop that service further, and I think there's certainly a demand for it to be rolled out to some of our other sites. Again, really has a fantastic impact in reducing the demand for general anaesthetic, because some of our very complex patients will always require treatment under general anaesthetic, and we have limited access again through partnership working with the Acute Trust at Kidderminster Treatment Centre. We just have one list a month there, and we do treat adults for all their treatment requirements. So unlike the paediatric list, we offer full comprehensive dental care and a general anaesthetic on that list. We also offer domiciliary services, so we have a limited offer in someone's own home. What we're able to provide outside of the clinic setting is compromised, but it's still an important part of our service where we're able to see those patients who are not able to easily access our clinics. We go out to them where we're able to.
Okay, so our urgent dental care service, we have an in and out of hours service, and these are for patients who haven't got access to their own dentist and they have urgent dental problems. Over the last few years, this is something that's been incredibly busy. As you know from the media, there's been a shortage of dentists, but we are seeing reductions in the need for urgent care appointments now because there are more practices in the area taking on patients. It's a really important service for patients to access help if they need it. They can access in hours through 111, who then send a referral onto the service, or there's a dental triage line where you have somebody who answers the phone and triages the patient and books them in for an urgent care. In hours, that would be at Worcester, Kidderminster or Evesham. And at the weekend, we have 2 out-of-hours services in Redditch and Moore Street. Those referrals solely come through 111. And it's a really important tool for people who are really struggling to access dentistry. And we get really positive feedback from that because people have often tried lots of areas with not much success at getting an appointment. We managed to get in, but it is for just to treat the problem they come in with. Sometimes it's only a temporary solve to their problem, and we always would advise them to try and find a dentist in the area, which has been challenging. But as we said, there are people taken on recently that have made that a little bit less challenging for patients.
So one part of the service that is rapidly expanding and we've seen recent investment in is our oral health improvement service. So this is an area of the service that's focused on upstream population-based interventions to improve oral health, and they are targeted and evidence-based interventions. Probably one that you may well have heard of in the press recently is the supervised toothbrushing programme. However, in Worcestershire, this is quite a well-established programme, and we've been working with 30 early years settings prior to the additional funding coming from government last year, and working really hard to embed a supervised toothbrushing programme in the highest need areas in the county. So those are settings that have been identified because of their demographic data, their health data, prioritising those settings where oral health is of the greatest concern in an area. In Worcestershire, we're very aware that we're fortunate to have one of the lower rates of childhood dental disease in the region, but it's important to not forget that that picture isn't uniform, and we do have areas in our population where oral health is poor, and these interventions can really have a significant impact on oral health and oral health behaviours in these areas. So it's an area that we're really proud is being developed and invested in by the NHS, by NHS England, but also our commissioners in the local authority as well. So in addition to the supervised toothbrushing programme, the team also provide training for care home staff, other professional groups, and not to speak about the specific groups that we're working with at the moment. And we're also commissioned to provide oral care packs, again targeted to those areas in the population with specific oral health concerns and in response to demographic data. But in the last couple of years, we've seen really exciting developments and additional investments for us to expand that service into Herefordshire. So at the moment, this is particularly looking at expanding the care homes training and professional training into that area. We're pleased that supervised toothbrushing is already delivered by Herefordshire Local Authority, so they continue to provide that, but there are other areas now that we are developing our new service. We're actively recruiting into that service and expanding into Herefordshire, which is really exciting for the team. A little bit about information about supervised toothbrushing. So as I said, it's 29 settings at the moment, but that is reaching over 800 children in the county at the moment. And these settings undergo quality assurance to ensure they're delivering the programme correctly and safely and in line with national protocols. They're receiving all the stock that they're required to provide that, and we get excellent feedback from those nurseries who are undertaking that training. In addition, there's active training going on. We're particularly targeting those groups of professionals that work with young people and those most vulnerable adults. So we work with health visitors and the family hub networks to ensure that their staff are well trained and understand their role in promoting good oral health practices, with foster carers and with teams such as Cranston, who work with drug and alcohol users in recovery. We also do a lot of work with our speech and language therapists. The care homes training, as touched on before, we're really proud that now we have over 65 professionals trained across the county, which covers 30 care homes. Excellent feedback from those sessions. But the model of training that we provide in care homes is that we go in and train professionals to become an oral health champion in their setting. And what we know now, as a result of training those 65 professionals, that over 170 professionals within those teams have had cascade training as a result of that. So that's really excellent coverage and improvement we hope to see in the oral health of our populations that are living in residential care homes in the county, and something we hope to then replicate into Herefordshire in the near future. Another area that's a smaller area of our service, but really, really important, is our involvement in the National Dental Epidemiology Programme. So these are annual oral health surveys, and they provide vital information which is used to inform oral health needs assessments at local level, but it also feeds information into the national statistics around oral health. So they're conducted to national standards each year. We're required to train and calibrate our teams who are involved in this. It's a significant undertaking. This year we have a full census survey of 5-year-olds across the county. So we go into all those schools, survey the children, liaise really closely with our fantastic school settings. Really significant undertaking. Last year was an interesting survey. We undertook some data collection of older adults in care homes. So you know, all works full circle and goes in to inform our programmes, such as our oral health improvement programme working in care homes. So it's really important to note we're not a general practice. We are a specialist service, and we only receive patients through referral. So we have two key referral pathways, really. We have those patients that are accessing the general dental practice, but unfortunately that general dental practice is not able to quite meet their needs. And they refer on a specialist system called RIGO, which is in use across the region for most dental specialties. So across the whole of the West Midlands region, oral surgery, orthodontics, special care and paediatric dentistry all use this system called RIGO. And however, that's not available to our non-dental referrers. And non-dental referrers do make up a significant proportion of our referrals into the service. So we receive referrals from general medical practitioners, from our community paediatricians and other specialists within our services. We receive a lot of referrals from oncology within the acute trust, from our learning disability teams, but that list is not exhaustive by any stretch. We see referrals from a wide range of healthcare professionals and social care professionals. And those referrals are sent in via email or post using our referral forms that are available on our trust website. Many patients, especially those that are referred in due to dental anxiety, will be seen for that single course of treatment, that current necessary dental treatment, and then discharged back to the referring dentist for their ongoing care. But we do have a significant cohort of patients who will always need our services, whose needs are more challenging and more complex and will never be able to be met in a general dental setting. So those patients remain within our service for all of their ongoing care. So all their dental checkups and all their dental treatment will remain with us as a service. I think it's really important to reflect on what we're not. So as I said earlier, we're not a general dental practice, and we don't take patients, as a walk-in per se. Even in our urgent care setting, it's via a triage, as Rachel said, either via 111 or our dedicated telephone line. We do find this a challenge because access to general dental services has been a particular problem, particularly since the COVID pandemic. And there are areas in our county which are verging on dental deserts, and I think an area of particular concern is the Evesham area at the moment, where there is very little access to NHS dental services. We do only provide NHS dentistry, so we're not able to offer some of the private treatment options that are available in wider general dental practice as well, and that can be a challenge. We no longer operate a model of walk-in in our urgent care centres, and that was something that was brought in during COVID and has remained. So we're operating a triage model, and that enables us to ensure that those limited resources are really targeted to those who have the greatest treatment need and have a truly urgent treatment need. And then we can signpost those other patients onto alternative options. We're not an oral surgery department, and we're not a hospital-based dental service. So some community dental services in the country and in the region are acute trust based. We're not, and this does bring its own challenges. So in Worcestershire, the acute trust operate the oral surgery department service. We don't run any clinics apart from the general anaesthetic lists in an acute setting. So this can cause some challenges for our patients who have really complex medical conditions, who would be best suited in a hospital setting, and therefore we need to work in close partnership with our oral surgery colleagues in the acute trust. And I think it's important to say we're not the only option for our patients with a learning disability and autism. So all dental practices in the region are required to complete Oliver McGowan training, and it's really important to say that, just because someone has a diagnosis of learning disability or autism doesn't mean that they must access care. And we're really keen to promote universal access and good access in all dental settings for patients. Often general dental practices are closer to home. They'll be able to attend with family to those appointments, and want to normalise accessing general dental practices where that's the appropriate and the best option. We do have long waiting lists. So where we can facilitate and support our general dental practitioners to be able to manage these patients well in their settings, we're really keen to promote that. We do have some gaps and some challenges. So we, as I touched on earlier, we have a high volume of referrals, and particularly for anxious patients, and we do have long waiting times, and that does sometimes result in feedback that is less positive, but on the whole we do work really hard to address those waiting times. As I touched on earlier, we're not functioning in an acute setting, but we are still seeing some really complex patients, so sometimes managing those patients that would benefit from being in a hospital setting is challenging. We're currently having some challenges, so we see a lot of patients out at home who ultimately do need to come into clinic and via hospital transport, and wherever possible we do facilitate that. But for some people who are needing to travel on a bed or a stretcher, we're not currently able to accommodate that in any of our dental clinics. So that's something we're really keen to develop and improve moving forward, so that we're able to bring these really, really complex, really challenging patients into a safe environment to manage their care in the best possible way. And then the challenge I just want to leave you on is our reliance on the acute trust for access to our general anaesthetic lists, and the challenges and that can sometimes bring.
Okay, so moving on with our patient feedback, as Natalie mentioned earlier, we're really lucky. We get some really good both care opinions and friends and family feedback. We had a new dental system last year, and that's really enabled us to be able to send friends and family forms, and it records it directly into our system, so it's really easy to pull the data off. And we are very fortunate to get some really positive feedback from our patients. I've got a care opinion here, which I thought told a really good story of a patient coming in. It was a little 9-year-old who needed her tooth taken out, and she wasn't able to do that in her normal dentist because she was too anxious and she struggled to even open her mouth. So she came in, and Snoba and Amy were the dental team who saw her, and they did a really good job at keeping her calm. And they managed to give her sedation with nitrous oxide and remove the tooth with using local anaesthetic, meaning that she didn't need to go for a general anaesthetic to have her tooth out. And they really liked the way that they used child-friendly words. They said things like feeding the tooth sleepy juice through a straw rather than saying we're going to use a needle to put your tooth to sleep. And it just was really sort of explaining what they were doing without being too informative and scaring the child. And the mother, when she came in, I don't think thought that the child was going to be able to have the treatment done. She didn't think it would work in that way, and she was really pleased that it did, and thanked the team for the job that they did there. So it was a really good patient story. Moving on to our friends and family feedback, we get lots about the incredible team. We have many anxious patients coming, particularly through our urgent care pathways, who have maybe, it's not that they haven't had access to a dentist, they've just been too nervous to go until they get to a point where they have to because they're in pain. And there's lots to say that the dentists make them feel at ease, really happy with the treatment, and they would recommend the service. And that when people have to have treatment done, we make them feel calm and they don't feel stressed when coming in, which when we're getting people when they've kind of not slept, not eaten, it's really nice to feel that they have those kind of positive experiences. We have lots about how good we are with children, particularly when there's children who come in with additional needs, that we kind of use a friendly approach. We sort of treat everyone as an individual and don't expect them to just kind of sit in the chair and open their mouth, because that's obviously the challenges they have, and that's why they're with us in the first place. We've made people feel respected and understood. People who were nervous beforehand managed to go out and felt that they had a positive experience rather than a negative experience. It's really nice to see the word respectful quite a lot, and showing that the team do kind of treat people on an individual basis, and that they do really support the team, the patients, and make them feel welcome. And about answering questions, we encourage patients to ask questions, and we answer them as best as we can, because that's what will ultimately improve their experience and make them feel less anxious. We had feedback about our hygienist was careful, and she explained everything well going through procedure. And another one saying we were accommodating to someone's son's additional needs and communicated well with him. And it was nice when people said we have a lot of people coming in very nervous and they just don't feel they're going to be able to have the treatment done. But with a little bit of talking and reassurance, we managed to keep people calm and get their dental treatment done. So hopefully they won't feel as nervous next time. Again, more about the staff. We have got a really amazing team. They are very friendly. They are very patient focused, and they really know how to engage with people and on their level, and know how to get the best results out of the treatment. Was one of the dentists extremely kind and patient, clear with her explanations, and gentle when examining this daughter who was autistic, a perfect professional. And to say that all the staff were absolutely amazing, which is something me and Claire, we think our staff are amazing as well, don't we? Okay, we do get some negative feedback. That's our positive there. As Claire touched on before, the majority of our negative feedback tends to be about waiting list times. And we have launched some initiatives this year which has really helped with our waiting list. It's more about providing some triage to the patient beforehand, to check that patients who've been on the wait list a long time, things haven't changed, they're not in pain, where they've been classed as a lower priority before. But also trying to pick out the patients who are willing to engage with the service and those who are not, giving people plenty of opportunity to engage with this, and then signposting them on to talking therapies and other services, because sometimes people just need to do a little bit of work with talking therapies before they're ready to accept treatment. Their dentist will refer them in, but they're still not ready to accept treatment, even with sedation at that point. So it's signposting them to the right ways to get their help before they get to them. They can come and see us again, and we can hopefully get their treatment done next time. We also have some things from our urgent care, because it's not a walk-in service. As Claire said, it's a triage service, but it is a sit and wait service. So we tend to tell everyone to come down at a certain time. The reason we did this is because we do find we have a lot of people not attend this service, so that if we know if people are coming down a certain time and someone's not turned up, and we do have another urgent call that comes in, it means that we can accommodate those calls and get those patients booked in. It is explained to people it's a sit and wait service, but sometimes people, when they come and they have got to wait for a couple of hours, they're not happy with the length of time having to wait. But we do try and communicate this at every opportunity. And there are some patients it's identified early on that they're not going to be able to sit and wait. We will try and make them the first on the list so that they don't have to wait as long as others. But we're always happy to learn from the negative feedback as well as the positives.
Great. And lastly, I just want to say thank you for Natalie for inviting us to talk to you today. But thank you for the investment that the Trust has made in the service over the last few years. We've all touched on and showed some photographs of our lovely clinics at Moore Street in Worcester and Orchard Place in Redditch. And we've recently received funding for a new wheelchair recliner, which is also able to be used as a bariatric dental chair. So that will further improve access to patients in our county who need that specialist equipment. We've seen widespread clinic upgrades, including accessible dental chairs and new cabinetry. But we didn't touch on the fact that we do have a clinic at the moment at Princess of Wales Hospital that we're not able to use because it isn't fit for purpose anymore. But we're really hoping that with the current changes to the hospital that we are in the process of developing a bid to improve that area and really make a fit for purpose suite that would be able to take patients on a stretcher if needed. We touched on earlier from our home visits, and really improve our links with our fantastic inpatient services at Princess of Wales as well. Thank you. Stop sharing.
That's brilliant. Questions. Thank you very much, Claire and Rachel. I'll invite those that may have questions. Sue.
Well, thank you so much for covering so many areas, which I think when we've been out on board visits, you've already addressed some of those issues with us, such as paediatric healthcare and some of the issues with waiting lists. And also at one point, I know that you were also dealing with shortages in the number of dentists available. One area that you've spoken about in the past on visits has been how you support the homeless people or maybe more transient populations that don't potentially have access to the 111 line. So I just wondered if you could say a little bit about those communities.
Yes, so we have worked quite closely with services such as MAGS previously, and we've had some outreach in Reach clinics previously going into MAGS Day Centre. We understand that they've undergone some staffing changes over there, and that's something we haven't been able to support so recently, but we do work really closely with them. They are a group who we are actively training and providing with oral health improvement materials. So they are in receipt of toothbrushing, toothpastes, link working with our oral health improvement team at the moment, and a team that have been identified and planned for team training over there at the moment. So Moore Street Clinic is traditionally a site where we have been providing additional support and signposting into, and it's an area that we're keen to redevelop and improve services in conjunction with the team at MAGS, because it's been really helpful going into services to really fully understand the challenges that their service users meet. But what we feel that we need to improve for them really is the bridging that gap between us seeing them at MAGS and then them being able to attend a clinic setting. So we do have fairly good uptake for urgent clinics and some good attendance and some fantastic referrals from both MAGS and Cranston and St Paul's Hospital as well, patients into the service. So it's something we're working to develop a little bit more at the moment.
We do also have a pathway, so if they do require urgent care, anyone who we would class as our hard to reach patients, and we feel that they're not going to be able to access the triage line, or they're not, able to wait on a line, we will book them an urgent care appointment, rather than kind of put barriers in the way of having to call numbers that we just know they're probably not going to be able to engage with. So we do make those adjustments, and the reception team are really good at kind of making those calls, or if they're not sure about something, they'll always check with a colleague to say, I think this person needs the service but can't access it, and we'll kind of work around that way with them.
Okay, thank you, ladies. It sounds like a lot is going on, and I'm really, really pleased to hear about your oral health improvement program. Can I just ask a little bit more about that, if you could slightly expand on that? Because I can see all the people that you're training, talked about health visitors, but I couldn't see like school nurses. And I'm just wondering, because now the NHS is moving from, treatment to prevention. Is there something about, or do we have a strategy that encompasses going into schools and also trying to improve, like your supervised toothbrushing? Because it sounds very, very interesting. And if it's not within our jurisdiction, is this something that we can influence influence the system to be able to do? That's one question. Then the second one is about, you talked about the urgent center. It sounds like people are beginning to take on more primary care dental service. Is there like a system strategy that we're putting into to encourage more of the dentists in the community to take on, so you're not overwhelmed?
So I'll pick up the urgent care first, if that's okay. So we are part of system working. We do work really closely with our commissioning teams around their priorities, and it is quite a recent additional. It's come from national government actually in additional investment in urgent care provision. So we have been engaged in that. To be honest, that's been quite new, and previously we have been quite overwhelmed by the demand, although we have been well supported by our commissioning teams. But I think that's sort of the new changes probably demonstrate the system working better now for all partners, and the additional investment in primary care systems. Going back to the oral health improvement in schools, so it is embedded in the national curriculum now, oral health improvement, and we're really pleased to support and encourage that where we can. We are mindful that is to go into every school in our county would be an unmeetable ask. So what we do is we signpost those schools to some fantastic national resources that are available to enable them to provide their own curriculum around oral health improvement. It is something we do get asked from time to time, but our commissioners are quite clear to say, us going in and directly delivering to the children is not a sustainable model for us. However, we do support schools to provide that. However, on those targeted areas and those targeted settings where supervised toothbrushing is going on, those settings do get a much enhanced level of training to provide that. So that sort of goes hand in hand, and they're talking about the new government model is aiming for 100% of the schools and early years settings in IMD 1 and 2 areas to be trained. And we are very close to that. We do have some settings, because there's no obligation for the schools to uptake it. We do have some settings that decline. So we work really hard with our local authority teams and with those settings to understand why they're declining, what the barriers are, and to improve the uptake for that. But we do have very, very good coverage in all our IMD 1 and 2 settings now. They've certainly all been offered, and most have uptaken that. So those do have quite an enhanced level of training, really, to enable them to deliver the supervised toothbrushing programme successfully. But we do work with commissioners, and when we're getting a lot of asks for additional, we do work closely with our local authority colleagues to highlight that.
Thank you.
Thank you both so much. Sue, sorry.
It was very interesting when you said about the system partnership working better, but you also touched on the need for sedation at Kidderminster and the need to work very closely with our acute colleagues. And is that a pressure that you're hoping the trust will alleviate, or is it a pressure that the system is working well to address?
I think at the moment the system's working quite well. We do have good working relationships, and our commissioners are in NHS England are particularly engaged with that relationship. And then our co-dependents, our dependents on the acute trust for access to those theatre lists, and they have actively been working on commissioning models that would support and strengthen that relationship better in the future. So it is something that our commissioning teams are very aware of, and we are very aware of as well. And we know it's something that we feel is a really important part of the work we do is keeping that relationship healthy and constructive, and at the moment it is very healthy in our dental services, but we're mindful that it's fragile. It is a fragile relationship.
Thanks, ladies. Thank you so much, Rachel and Claire. It's clear that you've got so much passion and commitment for the service. But firstly, you've done a cracking job of bringing forward the patient voice, both challenges as well as some really positive stuff. So thank you for that. Clearly, it shows you the importance of care opinion when we're listening to and want patient feedback. So that's brilliant. Importantly, you also, I think you've brought us all up to speed with exactly how your service works. So thank you so much for all of that. And please pass our thanks to all of your colleagues in dental services.
Thank you very much.
You're very welcome to stay on. You're very welcome to stay on. I imagine you probably want to crack on with your day, so feel free to dial off.
Thank you so much for your time.
Thank you very much.
Thank you.
Thank you.
Okay.
Thank you.
Okay, folks, we're a little behind time already, which is good. Great trial by fire for me as chair of this meeting. You're doing this on purpose, aren't you? Well, let's crack on with some of the opening parts of the meeting. Minutes of the last meeting. Are there any comments, corrections, or questions? Or can we all take those and sign them off and approve? So those are approved. Thank you. Matters arising and actions. There was only one action, and I think that's now completed, so that's fine. There are no questions or comments on that. We'll move on to questions from the public, which I believe are none. So that's good. Okay. And on to the chair's report, my report.
Now you're ahead of time.
That was all down to me. You'll have all hopefully had a chance to read the report, and it is an extremely exciting time, and I'm very honoured to be sat in this seat and acting as your chair. So thank you very much for the opportunity. Obviously, it's important to take a moment to note the huge contribution, but also the huge loss that we feel in respect of Mark's passing. He leaves a huge legacy, as we all know. It was very fitting to have the memorial service that we had a few weeks ago. And we all celebrated really the contribution that Mark made. And I think there were lots of smiles as well as a few tears on the day. I especially want to thank those that organised that event. It was extremely well organised. So thank you to Fiona and her team. And also those that spoke at the memorial, to Ellen, to Simon Trickett, the CEO of the ICB, and also to Sir David Nicholson, who shared some really personal stories of his time with Mark. So thank you all for that. In true Mark style, we've been celebrating staff over the last month or so since we last met as a board. And the staff awards took place a few weeks ago. 500 nominations were made for the categories, which is just fantastic. It just shows the huge amount of very positive work that's going on across the trust. And I just want to congratulate, and I'm sure on behalf of all of us, congratulate not just those that were winners, but also those that were nominees. Special thanks to our trust charity and also to the University of Worcester for their vital support. The care values are really important to us, and we recognise those on a monthly basis. And again, my report shows that we've recognised Malvern Ward, Kim from the Integrated Community Services, Lindsay from Orchard Service, Worcester City Neighbourhood Mental Health Care team, and also Jane from the Marketing and Comms team for fantastic way in which they work, and they exhibit all the values that we embed in our trust. So that's fantastic stuff. That's everything from my report, and I'm very happy to take any questions if there are any. Sue.
How do people get nominated for a CARES award?
Yes, Natalie, thank you.
There's a couple of different ways. We ask each of the operational SDUs to identify anybody through the integrated care governance process. So when we're talking about celebrating good achievements or challenges, they come up through that way. And then there's ways that I've identified. So if somebody wins an award or particular good practices identified, often gets filtered through to one of us. And again, we pass that on to Ellen and Kelly for a recommendation.
Thank you. Great. If there are no other questions, then we'll move on to Chief Executive report to Ellen.
Thank you, Chair. My report covers a number of areas. Obviously, you've covered my first area regarding Mark, because obviously this is our first board since Mark passed away. I won't cover that again. And thank you, Beach, for your kind words about the memorial. And I know many of the team that put a lot of work into that. What I will pick up first then is the changes in our executive leadership team. So this is also our first board since those changes have come into force. So obviously that is represented with the colleagues around the table, and we have recorded the appointments in the paper. So we'll run through those. But what I would also like to do is just to take a moment in our public board to note the contribution and achievements of colleagues who have moved on to other roles now outside of the organisation. So it was obviously difficult making the choices that we've made, and it is in no way a reflection of any lack of appreciation for the contribution that other executive colleagues made to our organisation. We also have a post which has gone to advert now and is currently live around our new role for Director of Patient Experience, Digital and Innovation. And I'm pleased to say that even quite early on in that process, we're generating a very significant amount of interest in that role. So I will keep the board posted as we move forward. We also then move on to a number of other things that we would like to bring to the board's attention. So we have opened the new Bromsgrove Minor Injuries Unit now, that opened on the 6th of October. Having visited that facility a couple of times now, first when it was in its development and now when it's open, it really is impressive. And I think credit to the estates team who led that development, and also fantastic to see the team now established and using that unit and the facility that it offers. We also hosted our local MP, Bradley Thomas, on Friday, October 31st. So yes, a great facility that we now have to offer to that local population. I should also say that as part of the same visit, we also formally noted the opening of the new sensory room at New Haven, and that is also a fabulous new facility that we've got for our local population. We have also to note that the 0 to 19 Public Health Nursing Service have been awarded the Stage 1 Baby Friendly accreditation, and we also have plans to progress that, as we had achieved Stage 3 previously. So I know the team are ambitious about moving that forward. We also pick up in here about the flu vaccines. So we're making great progress. But obviously always more that we can do, and we've had a targeted comms programme on trying to encourage staff positively to take up vaccination opportunities. We also marked Black History Month in October. This year's theme was Standing Firm in Power and Pride. We had a number of celebrations across the organisation, and it is really an important moment for us to celebrate our commitment to equity, inclusion and anti-racism. We also, I particularly enjoyed joining in with our Wellbeing Day for our international nurses on Friday, 24th of October, and hearing firsthand from some of our colleagues, both the positives and the areas for improvement, the even better ifs, about how it feels to join our trust as an international nurse. I mean, I, for one, was struck just at the resilience of some of our colleagues who, maybe it's a sign of my age, but seemed very young to be coming so far overseas and embarking on this career in a new country and all that goes with that. And so everything that we can do to provide that support, that pastoral support, is really, really important. And it was heartwarming to hear about where that has worked really well with some of our teams, as well as I say, the opportunity when they've heard back about how we could do better. And I think, really want to learn from their experiences and continue to develop the offer we make, because they provide such an important contribution to our trust and to our workforce. This seems quite a long time ago now, but actually is since the last board that we took part in the Baton of Hope tour as it came through Hereford. So that was also an important opportunity The baton is a symbol of hope, resilience and collective responsibility. And we were really pleased to take part in that alongside a number of partners in the public sector and BCSE sector. I've also included a bit of a summary and out and about section in my report now, just to share a number of the places that I've been and some of the visits that I've had, and happy to take any questions on any of those areas. I've also particularly enjoyed visiting some of our voluntary and community sector partner organisations and hearing about some great joint working. So I had a really informative and interesting conversation with one of our, she's a local resident, but also a patient in some of our crisis services, but also taking part in programmes at the Cart Shed in Hereford. And she talked about how she's really appreciated support from the community mental health team to access the Cart Shed and what an important contribution it's making to her health and well-being. So therefore, for me, really reinforcing how that partnership working provides really holistic offer to our patients. That's so important. Moving on then from some of our more local organisational things to our local system. So again, this feels like it's now a little bit, maybe it's a sign of how quickly the world seems to be moving at the moment. But actually, since we last met formally, Simon has been confirmed as the Cluster Chief Exec. And we also have had the Integrated Care Board commissioning intentions for 26-27. And we have done a formal response to those, which we have shared with board members. So I hope you've had an opportunity to see those. And in the same theme, really, around planning nationally, we've now had the medium-term planning framework. So we are working hard. The timescales, as ever, are quite tight in terms of pulling together our plan and still evolving finance guidelines around the actual detail behind the allocations and so on. We've also recently had another period of resident doctor strike, which we're just very recently coming out of the back of. It's been in the last week or so. And I just want to take a moment to thank all colleagues who stepped up and provided support to ensure we had continuity of services. I know Scott and other colleagues had a very busy weekend of on-call, not just due to IA, but due to some of the weather adverse events that also impacted. So it was a bit of a perfect storm, no pun intended, both Claudia and IA all coming at once. And we just would like to know, I think, thanks to the board for everyone who has stepped up to support resilient services during that time, both clinically and operationally. I'm not going to go through any more aspects in the report. There's a number of national guidelines that we've flagged here. So just there really for the board to note, but I'm happy to take any questions on any part of my report, and thank you.
Sue and then Colin.
Thank you very much. It's a very good report, and particularly I enjoyed seeing all the things that you're going out to visit, which is great. You included the Learning from Life's Deaths report. Is it called the Leader report?
Leader,
yes.
Yes.
And I noticed that in that it talked about reasons for unavoidable deaths included problems with organisations. And I just wondered, within our own organisation and within the system, how we do our best to support people with learning disabilities so that they don't suffer the inequalities that we see in that report.
Yeah, incredibly important. I'm going to hand over to Natalie in a moment to comment on that. But just to say, we will be having a more in-depth probe on some of the leader findings in this board as a later date. So just so you're aware.
So yeah, we work really closely with the system around leader learning, and that feeds back into our organisation. But more importantly, she said, how do we enable all of our services to ensure that they are accessible and make reasonable adjustments? And that's through something called the Green Light Toolkit that we do every year. It's led by one of my deputies, Phil, and it's about working with all services to identify how accessible are you, what differences could you make? And it might be a minor tweak, such as we introduced a pilot of having the noise defenders in our MIUs, because if you've got a planned appointment, you'll probably take them with you, but obviously MIUs are often unplanned, so having something different in an MIU to make the experience more accessible And it generates small ideas, but gets every service thinking about their accessibility. And obviously, it'd be remiss if I didn't mention the Oliver McCowan mandatory training.
Yeah.
That we know we're not quite where we want to be as a trust, but we are again relaunching with a new training provider, and that's a really important focus for all of our staff.
Yeah. So just to build on Leslie's point, we would be happy to share that plan, but we've just taken a plan through the executive team. It's a 3-year plan. And it will take it's relatively modest investment, but investment from our organisation with a plan to really drive that through to the level of training that we'd like to see in place across the whole organisation.
Yeah, well, I know past the board we've all done that. It was good and it was useful training to do.
Comment.
Questions on the minor injuries clinic. And twofold. One is, to what extent have we been able to publicise and announce its presence, and what communications have we used? Following on from that, I know it's early days yet, but what's the take-up?
The take-up is enthusiastic, I think it's fair to say. But yes, we have done some targeted comms. We have been, I mean, the MP, for example, said he was publicising as he goes out and about, talks about it. I think making it clear through our own media channels and our website and so on what the offer is. I think one of the things to say about our minor injuries offer is that it would be possible for us to provide more from that service, but it's something that we need to, how would I consider in the round in terms of the system appetite for that. So we're not actually using all the rooms at the moment. We could use more, but that would require investment, of course. And we need to balance that against other priorities in the system. But if that's something we are able to get system support for, we would be very enthusiastic to provide more. And I certainly think the footfall is there. Were we able to do that?
It's handling something in the back of mind that I may be totally wrong, but I thought something in the 10-year plan was a commitment to reduce walk-ins at A&Es generally through these types of alternative offers. So surprised to hear that the system.
Well, it's absolutely, and I've chosen my words carefully because I recognise the challenges of the system finances at the moment being in a deficit position. So, excuse me. So it's absolutely in line with hospital to community, and it's the right direction of travel, and we're ready to do that. But we have to recognise the overall context of the system finances at the moment. But that's something we've got a shared commitment to work on. What's the art of the possible? And I know that certainly I've had very positive conversations with Worcester Acute Hospitals as well about how we could try and maximise that facility. Because clearly it's in all of our interests, population interests, using that facility. It's in the interests of overcrowded A&Es to direct activity that can be taken to minor injuries. And I think there are a number of ways we could develop the offer there, that include things like networking in with central acute hospitals, so you can provide digital links for clinical support. There are other examples like that around the country, and we're really keen to look at those and think about what's possible. I suppose the good thing is the unit we've built is future-proofed in that when we do get to the point, and I think it probably is a when, not an if, when we do get to the point we could put more work its way, there are rooms that we can
Keep us posted.
We will, yeah. I think it's exciting.
John.
Sorry, I wanted to come back on to
My apologies. I should have let you in earlier. My apologies, John.
Just to add to what Natalie mentioned, we have a system learning disability program, which is chaired by the Chief Nursing Officer of the ICB. And within that, we scrutinize the leader report and the local findings as well. And we undertake some very specific interventions to address those. So we also have the Health Inequalities Ambassadors. I'm for the learning disabilities, and Sue Alice is for mental health. So we kind of are part of that program board addressing specific health inequalities in this population. I suppose the other thing is most of the kind of physical health conditions identified in the leader report that obviously bowel type conditions. They So those have been taken into account, and for quite a few years, in addition to the Green Light Toolkit, which is, a kind of an audit tool for mental health services, you've got what is called learning disability national indicators, which are trust specific, and those are undertaken at an organizational level settings to audit themselves about how they do, and those are kind of discussed at the Learning Disability Program Board as well. So there's a bit of a system-wide response to leader report.
Thank you, John. Apologies again. I should have. You should have jumped in earlier. Ollie.
Yeah, Ellen, wonderful. It was really good to hear what's going on. And I think that's what brings me to my question, because a lot is going on, but we also have these leadership changes going on. And that's what I want to ask you about. How do we make sure that we maintain continuity and we don't lose momentum while we're going through all the changes and improvements?
Yeah, it's a really good question, and I think everybody who's here, so the majority of the team, have worked really hard to ensure that we have had continuity in terms of some of the areas where people have been picking up new work. I think it is a very busy time at the moment, incredibly demanding, a huge amount is going on. I think it's inevitable that around some of the digital innovation, we may have a brief pause while we're kind of going out to recruit that role. It's probably worth me just noting, actually, for the board, my thanks to Robert Mackey, who has agreed to supervise the digital team. Obviously, Robert, you did have digital in your portfolio previously, but you're also quite busy with all the finance business that we have at the moment. It wouldn't be fair for me to acknowledge that. But I think I'm comfortable that a short pause probably won't stand us in too much of a tricky place, but we are staying abreast of what's happening in the planning guidance. And I do hope part of the reason why we've pushed to have the interviews before Christmas is that we really do want to get on with this appointment.
I think that's what I was concerned about in terms because of all the fast-paced work that is going on around it. Yeah. So thank you.
I'll just add, if I may, on that my thanks to everybody on the exec team, including Ellen, on the basis that we had, sadly, Mark's passing come around at exactly the same time that Ellen was going through some of her changes. And for that exact reason that you put that question, it felt very, things were moving around. But I think the maturity with which all of you, the exec team, have stepped up and remained focused and therefore focused your teams, I think has been fantastic. So my personal thanks for all of that. Sue.
May I just go back to the MIU in Bromsgrove? To what extent are you able to educate people in the community, including stakeholders like GPs, about what the centre can and can't do? Because I think when Natalie and I visited Evesham, there was an expectation, which was also fueled locally by people being sent there, that it could do things that it couldn't do.
Yes, no, it's a really good point. So there is a significant comms theme that goes alongside the system winter plan, and that we are a part of as well. But I think it is perennially an issue in terms of, because we haven't always been consistent about the offer as well. I think we do have to own that. So sometimes things are and are not available. So I think the onus on us is about trying to ensure continuity and clarity of what the offer is, and being part of that system communications piece where we're publicising that as much as we can. I think also there's something about some of the work we need to do within the system as well, because we know sometimes, not always, I think sometimes this can be slightly over-egged as an issue, but I do think nonetheless it is an issue where people are misdirected through our first contact services like NHS 111 and so on. So I think our kind of ongoing work to make sure those links are well established and we're as clear as we can be in the background are really important as well. And that is something we do work on. But I think, of course, now we're looking at potentially that offer will evolve if we do manage to do more around. People may be familiar with the term urgent treatment centre. So the national guidance on urgent treatment centres has evolved quite considerably. So it used to be the case that you could only call it an urgent treatment centre and have that fully in place if you had medical cover on site. Now there is the opportunity to do that in more of a networked model. Where I was talking about things like the video consultations and so on. So I think that's certainly something we're very keen to explore. But I think that publicising, doing the comms, that's going to be something we're just going to have to keep doing, I think, in perpetuity, because it's not always clear to our patients, which I think is, inevitable with the actually some complexity of offer there is now across the NHS.
I just follow up on that, just because comparing the dental office, so obviously the dental office there is a triage, you can't just walk in. With the MIU, you can just walk in. Are there places where they do a triage prior to walk-in, and is that something we've considered?
Yeah, so in fact, in my last system, it was a book. MIU had largely moved to a booked model. There are pros and cons with that, I have to say, but it was something that we have made the transition just across the border in Gloucestershire, where that's a bookable service and people would get a slot and they could book that either directly through a number that was hosted by Gloucestershire Health and Care or through 111. So I think that possibly is a direction of travel. I think some of the challenge, having sort of lived with that system for a while, is that that did lead to sometimes a lack of flexibility, where it was always meant to be open for people to just turn up and wait as well. But we went through periods of time where the MOUs would say, well, we're closed now because all the slots have been booked. And then that would mean everybody would go to the main hospital sites, and that, as you can imagine, cause some consternation in terms of system dynamics and system working. So I think with care, it is possible to have a more bookable service, which can obviously help some of our patients not just having to turn up and sit and wait, have a planned slot.
Thank you, Anna. We'll move on to the next section of the agenda, which is performance patient experience. In fact, I should have noted at the beginning that you may have seen some changes to how the agenda's working this time. Hopefully, we've taken on some of the feedback that many of you have given about where we can strengthen the agenda and we can specifically focus on certain areas. And that's starting to represent itself in the agenda. You may see further iterations as we continue to improve. And Ed and I will be very keen to hear from folks after the meeting about what we felt. Patient experience report, Naomi.
It's going to be me, actually. So thank you. And partly that's because patient experience currently sits between mine and Sue's portfolio, so we thought it might be helpful if I kind of covered this. And it's just it's a summary of the activity that's happening under this experience and engagement setting. So just to outline the work we're doing again with care opinions, and now we are rolled out across the trust. And again, to reiterate, so the messages we saw earlier, they are responded to by a member of that team. So this is not a corporate response. So it gives that real lovely ownership. But we continue to really maximise how we use that. And you heard really helpfully how it's connected with the electronic patient record in dental, which gives them a real clear sense of what's happening. We also have been working on making sure that we triangulate what we're learning through patient experience feedback. So using the CQC fundamental standards enables us then to think about what are the themes that we can focus on with that experience. We continue to use on-site advocacy, who provide an incredible advocacy service onto our mental health inpatient wards to really capture that. How does it feel to be a patient here? And then how can I help the ward and the team improve and make my experience better? And being independent, that's a really strong advocacy voice we have. Health inequalities within this portfolio, we have the Carers Oversight Group, and we have a Health Inequalities Group that also has now a new accessibility working group that's looking at the new accessibility standards. And whilst I think we will acknowledge our Health Inequalities Implementation Group has identified lots of great initiatives across teams and services, there's work we can do if we improve the data we have to take a more strategic approach, and that's what they're working on now. We have really active participation partners and volunteers in the organisation. And again, just wanted to hear what's it like to be that person in our organisation. And you can see from the report the fabulous feedback. About 94% said they'd recommend that role within the trust and cited the support they give. And we rely heavily on that through volunteering, co-production, in lots of different ways. So it's great. They offer a great service to the trust. I think then the final reflection is how we're really looking forward to our new executive arriving. I think we've got some really good foundations to build on, but now we're really looking forward to that new executive. We're having this focus on how do we really solidly embed co-production, co-development, and that real focused patient voice through all of our innovation and digital work as well. So that's, I think, a summary of the report. Okay.
Thank
you. Yeah, I think Care Opinion has been such a success story, and I wish we could harness that enthusiasm for the staff survey. Anyway, by the by, but I did wonder, do we have an awareness of which parts of the organisation still have low uptake or low responsiveness on Care Opinion, and if so, have we got to the bottom of what the cause of that is?
Yes, we definitely do, and that's the same for the friends and family test as well. So trying to triangulate that information. So, for example, we identified Care Opinions, friends and family test, absolutely no uptake on acute mental health wards, virtually none. So that's why we engage alongside advocacy to say we need a different way to engage with people who probably are too unwell at that point to utilise one of those processes. And we've tried multiple things to try and get families engaged, and it didn't work. So we identify those services. We use that again. We mentioned integrated governance earlier. So we bring feedback through that process. So making sure you've got some form of engagement tool, whether that's friends and family test, with sexual health, uses that brilliantly. That seems to be that preferred services choice of feedback, which is great. Certainly things like our neighbourhood teams, that's slowly building for both mental health and physical health. So it's really thinking about how can we use our electronic patient records to push out a request for feedback. That's worked really well for dentists and dental service. So yeah, we've got initiatives that happen and we carefully track it, but it's still not everyone's as engaged as we'd like them to be. And I think the other point to note is the staff anxiety around, gosh, this is going to be really time consuming because it's not a PALS team responding to it. Once teams are up and running, they haven't found that at all. They really love that little bit of feedback. And I said, it's not a corporate response. It's just a jump back on and say, thank you, we're going to do this. So it's really, really fluid. So yeah.
Yeah, thank you so much for that. And I guess following on from what Veen is talking about, for me, it's about the possibility of excluding people that are not digital. Because we're moving everything now to digital, isn't it? And that's which is right, because that's what nationally we're being made to do. So how are we making sure that we're not excluding people who are not so digitally able? How do we make sure we capture their voices as well?
So we have, again, the old traditional leaflets, posters across the whole organisation. Care Opinions is a telephone number as well as an online form, so you can phone. We get lots of people phoning up our PALS team and giving compliments through there. We log if services get a thank you card. We log that through Ulysses, so it gets pulled through into compliments through PALS. So we capture that feedback through as many sources as we can. So it's not just about the digital response. And then we use things like the carers oversight group and the patient panels to get that other feedback to be as rich as you can, because you don't want to exclude anybody.
And we're going to make sure that is sustained going forward. The more we're being pushed. Okay, that's right. Thank you.
Thank you. Sue.
So just got two things, and it follows on your reply about using acute mental health services not potentially responding to these, which is understandable. And I might be mixing lots of things up here, but we are reliant on feedback from our mental health service users for our sense to what extent we are doing well there, aren't we? Because we talked about inequality about the survey. So is there a link there, or is there more we need to be doing there to get better response, better levels of response?
Yeah, so the inpatients and community surveys are annual surveys, which are helpful because they give you that once a year view of how the services are performing, and our response rates are average, a little bit above average on those, but there's always, yes, absolutely more we can do to improve that. It's that day-to-day capturing of how does it feel to be at the end of our services today on a ward or in an acute team. That's the challenge of how do we do that with, people might not be trusting of the staff, they might be in a difficult relationship with the staff, so having somebody completely independent to advocate that voice, that's the powerful bit for us, and we can build on that more as we move forwards.
And just Vina's comment about the staff survey, I noticed that some trusts do a staff experience report as well as a patient experience report, and I wonder if we've ever considered that.
Yeah, it's definitely something we've been looking at. I mean, obviously we have been much better with the staff side about the triangulation as well from all our different kind of data sources. So yeah, it's something that we can take forward.
Thank you. Two things. I mean, I think first of all, recognising this is a really strong foundation, but I am really looking forward to the new person arriving because I think there's other conversations to be having. I think there's more to be done in terms of actually sort of like co-production of services and really getting people's voices before we get to the point of designing their services. But that's quite a resource intensive piece of work to be done. But I think it's something that we as a board need to keep an eye on. The other thing I'd just like to recognise today is a Carers' Rights Day. So it's a National Carers Recognition Day and very much a focus on what people can expect. And I'm really pleased that the work the Trust has been doing through that carer oversight group, which I managed to get into sometime and hear what's happening there. But certainly in terms of our staff who are carers, as well as the carers we're supporting through the Trust. So just to acknowledge that is today.
Absolutely right to mention that and their contribution. Thank you, Carl. Thank you, Becky.
Pleasure.
We'll go to the performance report. Scott.
Fantastic. Well, thank you. Obviously, you've got the report there. It is a new style report, so obviously any feedback. I would also say that obviously I'm only about 8 weeks into the job, and actually how I've written the report 2 weeks ago, there's various things that I've done slightly differently if I wrote it now. So I'm actually going to bring those bits out verbally. So if you just forgive me on that one. I think the place I really want to start is it's been a very busy job, and it's been great spending time with as many staff as possible. And thought what I'd do is start by sharing with board some there's really 4 key things I've really been trying to work on with teams, and the teams have really responded well to these. So firstly, thinking about our partnership working across the system, and how we really enact that at an operational and clinical perspective. Being forward looking, so what's on the horizon, so that we're trying to lift our heads out of the here and now. Owning our own issues, so it's very easy to other or externalize problems, but actually let's own things we can own and put those right. And also the 4th thing about the real importance of empowering and engaging our staff. And those are really the 4 key areas that I've been focused on. You'll start to see that perhaps as we do go through the report. The other bit I'd add to that is some of the feedback that I've had of what people in the organisation want. This does build upon the 1,000 Voices from a couple of years ago, the work Ellen did on her first arrivals, and there's a couple of things I really want to pull out there which I think will become important over the coming weeks. The real importance of clinical and professional leadership through our structures, and how we make sure that that is really embedded and part of how we drive our services, but also acting on the voice of our staff. So one thing we are going to do differently this year between me and Robert, and Alan, we've agreed that our capital this year will be focused on the snagging issues, the hygiene factors that have really caused our staff issues over the last few years. So we'll be, whilst we heard from Dental this morning about some of the great bigger investments we've made over the years, we're really looking to work with our associate directors to make sure those small items are addressed, those things that make a difference to people on the shop floor who are delivering care with their patients day in, day out. So I think there's perhaps some of the high level bits I want to say. Stepping into the report, what we've got here is a combination of the NOF and operational updates. So in terms of the NOF, it hasn't changed since the last time we've seen it because of the reporting period. But just as a reminder, it is updated on a quarterly basis. Some of the metrics, though, they only change on an annual basis. And the National Staff Survey, which is currently open, drives some of those metrics. So we may well see some significant changes for organisations over the next quarter. We'll just have to wait and see. And also, I think there's some of the metrics are going to be revised as well. So that might well, again, drive some changes. Overall, for our organisation, though, the metrics are presented there. As we know, we're in NOF 3, and it was because we were very slightly financially off plan, but we're back on plan. So we're hoping the re-review that's something that might change, but we'll have to see. Listed in the report are some of the actions we're taking against the areas where we are less positive in terms of our scores. For instance, with putting a real focus on those long waiters, certainly through our paediatric service. These are some of the areas that I'm really wanting to put some focus into, understanding our waiting list and putting in corrective actions to make sure we are tackling those issues. Some of the service highlights. Now, very sadly, when I wrote this, I was able to say we're continuing our run of no out of area placements for mental health services. Unfortunately, that came to an end this weekend. And sadly, I was on call as well, so I have some things. I was, but there's, we did go into the weekend with no beds, and the teams are doing some rapid reviews about actually what is it we could do differently next time, and to make sure that we've got the capacity there when we need it. But that doesn't stop it was about 190 days, I think we got to, the amazing work of the teams, and that piece about owning our own issues, being forward looking, putting in a plan and really owning it. It's a real success story, and the team, whilst they were disappointed about losing the run, there's real determination to make sure we understand why and how we put those changes in place. Moving on into the physical health space. Before we move on to from mental health, we've really gone and worked with the One Herefordshire team to really make sure that there's our place as an organisation in delivering neighbourhood health in Herefordshire. We've been really, really clear, but we'll be around the table working with partners to make sure we're shaping and deploying services appropriately. A couple of bits within physical health. So we're doing a really good job through community hospitals. Our rehab length of stay is in a positive position. We do have struggles around some of the long-term care planning aspects, but we're working with partners to manage those. Also working very closely with partners about what the future of community hospitals is. Children's services, over 52 weeks been eliminated from our children's physio service. So I just wanted to congratulate the team for the work that they've done there. There is still obviously an awful lot of work to do in other areas, but just really, really want to recognise the progress that they're making there. As part of our partnership approach, we are working with the commissioners to develop 2 3-year plans, one around paediatrics, one around neurodiversity, so that we have a shared understanding of where we want to be in 3 years, what is it we need to do as a provider, and what the investment is from commissioners. So those are probably some of the highlights and areas I'd pull out. Obviously, happy to take any questions.
Thank you. See you then on you.
Well, there's some great reading in this report, and I had lots of tips, including the inappropriate out of area with child untick. I was very interested in the bit about the Frailty General Medicine Hospital at Home service, and that's a great, example of great partnership working. But then just immediately afterwards, you talk about UCR and the winter plan, and we know that has traditionally caused a little bit of pressure on our community services because they might get pulled into that urgent community response. So how are we making sure that other things are not impacted by doing that vital work?
Yeah, no, and you're absolutely right. Again, this part of my answer is going to be about forward looking and how we do things in the future. And there's another part about what we do here and now. So on Monday, I'm doing a walkthrough of services with system partners to make sure we understand and who's doing what, and so there isn't duplication. The specific UCR piece, I've started conversations with commissioning colleagues, ambulance colleagues and acute colleagues about what that service might look like going forward, as we need to be able to meet that urgent need whilst also supporting our business as usual. That's an area that everybody recognises key part of the model going forward and something that we need to further develop. So yeah, I'll be happy to talk through those plans with you more outside of the room, but it's actually quite an exciting area of development over the coming few months.
So do you anticipate those changes to happen this winter, or are we looking for?
Some of them. I mean, certainly in terms of the way we reach into the acute, simplifying that. How we simplify referral, how we encourage paramedic use of UCR, so those bits certainly. But in terms of some of the wider pieces, probably looking at development over the next 12 months.
Robert, was yours following that?
It was just a couple of builds on Scott says, just a couple of span for where we are with an off. Those bits of it in and just a bit about.
Why don't you do that now? Then we'll continue.
Yeah, so it's just to add a little bit to what Scott said. Just a reminder that the NOF is quarterly. So the last one, which we are expecting to be published at some point in November, was taken as at the end of Q2. So that's there. We're not expecting any changes to the framework until the new financial year, so that'll be from April. They are consulting on some changes specific for mental health trusts. So there's likely to be, as Scott said, some changes to the framework. And then it's just the piece, then there's obviously always a bit of a lag in that, so that will take us next year. And then finally, just for board, just to note here, we did submit our providing capability assessment. We're also expecting that to be reviewed and published at some point, hopefully the new year. And that is the other kind of formal part of the NHS oversight, frankly, I would say, just to note for all of those things.
Thank you.
Thank you, Scott. That was really, really helpful. And my heart breaks for us in terms of because that was a big celebrated area. And I was going to ask you questions around that, actually, about the risks, because we're in winter. We know this is when things tend to fall apart. So since it's already happened, have we had the headspace yet to reflect on, where there are risks that we did not foresee? And if we have we started putting contingencies in place to make sure that, we recover the position and we sustain it going forward? Because it's such a good news story that we want to keep. And before you come in, my second question is on the veterans ward, because the way it is in the paper talks about us expanding depending on full staffing and all that. So the risk there as well is, do we have any contingency? Should any of the recruitment, retention, if it falters, do we have any plan B to make sure that we carry on?
I'm happy both of those. So in terms of the risk around when we went into the weekend, there weren't any beds. And actually, through the work the team has done, there were opportunities around people who were in our beds who are out of county. And actually some of the preparation pieces. So there's some operational stuff that we've picked up there. And it's, I have to say, the way that the team has embraced, yes, there's a bit of disappointment, but absolute determination to pick up and go again. So, you know, it's John, my phone a friend on the weekend, was whilst we're busy looking at every possible alternative. Again, we've had conversations about a couple of things we could look at as well, which are being taken forward with teams. In terms of virtual wards, so the recruitment processes have actually completed now, and offers have been made, and it's just then the process of when can people start. So in terms of being really ready for the depths of winter, and looking at how we can support all hospitals in Worcestershire get down to 90, if not a bit lower, % occupancy pre-Christmas. Those plans are all coming together at the moment, and Oss Hospital Home, there'll be a key part of that. So I don't really feel the need for an extensive mitigation plan at this stage. So I'll keep a close eye on it. Okay.
Yeah, no, I just wanted to add something actually, which is I think it is important to not see it as the programme has sort of somehow fallen apart, which is just a small blip in a really great performance. But I think there is an important point which Scott did draw us at the beginning, but I'd just like to reinforce really, which is our learning from the community hospital work, from the mental health centre stay work, some other pieces of work that are going well, is that clinical ownership is really, really pivotal. And I would just thank also John and their leadership around those areas of work. And I think that triumvirate piece working really strongly together is what has led to the success there. I was actually with the Herefordshire consultants yesterday, who were reflecting on the ownership they felt and how that's been really different to how it felt in the past. So I think there's learning there. And I think the other thing is to then how we can apply the same point to some of the other areas where we can see we need to do better, particularly around like the children's services that you've drawn out, and are starting to really understand how we can drive that forward with a new energy now.
Thanks, Scott. I too welcome shift in emphasis of the report. I think it's really positive. Questions really relating to points we've already raised, just slightly different direction maybe. On the hospital at home, the 30 beds, virtual beds, is that a major shift from the system? Because if I recollect correctly, this has been on the structure quite some time, and maybe simple some reason. Give us a background of that.
So certainly that does pull out the theme of partnership that we discussed earlier on. So as a team, we've been working closely with our counterparts in the acute setting, and there's a number of things in there in terms of teams obviously being ready to release patients in service, and there being the appropriate capacity, the appropriate skills in the receiving team, and the clinical to clinical confidence really that this is really part of the pathway, and it is that clinical ownership, clinical confidence, and partnership working that will make this work. So whilst there's been the investment from the ICB, which is significantly appreciated, it really is about our teams working closely with the acute teams to make this work, and the relationships there are good. There's confidence is improving, and I really do feel like it could be a really valuable part of the system response this year.
Right. Could just chip in another little sort of follow-on question. It's not really clear what our anticipated impact is going to be. It's bottom line being financially focused, but in terms of quality, the future reports, is it possible to?
It certainly is. It's going to be an evolving report, so any feedback's welcome. And yes, if it's what we're trying to achieve, what impact we want to have, that would be and when we know we've got that.
Thank you. Yeah, I have a kind of a similar question, Scott, but in relation to the ongoing pressures in neurodevelopmental ways. I feel like we've been talking about this for a long time, and it's a national problem. But I wonder whether we are really crystal clear about what good looks like for those neurodevelopmental pathways, and when will we reach it? Are we clear about timescales?
The honest answer to that is no, we're not clear. The point of doing the 3-year plan with commissioners is so that we've got a shared vision of where we're trying to get to, what the timescales are over there, and what the inputs are. So some of the inputs is us doing things differently, us working more efficiently. Some of the other inputs are around investment and what the commissioner wants to see, both in the service, but also from other aspects of the system. So the approach we're taking to develop the 3-year plan will drive out those responses. The plan will be ready by Christmas and reflected in our planning submission. So at that point there, it might be something that obviously it is of key focus for the board. Perhaps it is something we take through a development session in a bit more detail.
Oh, sorry, just a sneaking question. Presumably there are mitigations in place. I mean, the 3-year plan sounds it's like daunting. So
yes. I mean, we've got some really strong leads in the space. And they're working with their teams to how we can make sure we keep people safe, how we prioritise clinically and reach the people who really need us. At the same time, Commission's obviously got various outsourcing options in place as well. So it's about us working together.
Just as a way of celebrating what the charitable funds do, as a precursor of what we're doing this afternoon, when we heard the dental, we heard about the bariatric chairs, which are supported by charitable funds. In Malvern Community Hospital, we are also financing some chairs which allow people to release a bed and to sit out in an appropriate way. And I just wonder, is that something that could be rolled out to other community hospitals, or is that something that everyone else has got already?
I don't know the answer to the question.
It's variable, yes, and we are relatively. It's a great option to have. It's called Fit to Sit.
Yes.
But a lot of our patients who are leaving our community hospitals are not able to sit. So whilst it's a good option to have, it will have a small but important impact. So yes, it's that balance of how we do it. But yes, we could be beneficial elsewhere as well.
Yes, I had one further reflection on the report. We've talked a few times today about some of these reports having a bit of a refreshed look and being a work in progress, as well, as we should always keep our papers under review anyway. But I wonder if there was the earlier point made, and I apologize, I can't remember who made it, but regarding the staff experience report. But I wonder if perhaps the answer, because I had been reflecting myself that on the NOF domains, at this point, our report is quite light on the domains outside performance and operations. And that's something we reflected on when we looked at this as an executive group previously, and whether actually this is the space we could develop more in the people and workforce domain, because it is part of our NOF framework and include in this report at the next iteration. So I wonder if the board would be content if we trial that and see if that starts to cover what we need. Would people be happy with that?
Very unanimous support on that one. Any other questions or comments? I think you see from the quality and quantity of inquiries, Scott, all eyes are on the performance piece, and really grateful for the effort that you and the gang have made, especially in some challenging times that we've just had in the last few weeks. So thank you. My questions on out of areas and compete have been taken care of, so you don't have to feel scrutinised any further.
Welcome scrutiny.
Thank you.
175 days.
Sorry?
175 days.
Yes, it's called a streak, I think, on Duolingo.
Really good. Really good. Yes.
Um,
You can freeze your streak, so maybe we just say we froze it.
Let's freeze our streak.
Yeah.
Freeze our streak.
Yeah.
And I see a little pattern amongst the Neds of double questions as well, which I think. That's good. All of you consistent on that one, so that's good. I like it. It's approved. Right. We've got the finance report next, Robert.
Yeah, thanks, Chair. Probably two key bits I want to draw out here. There's the first bit I'll pick up, which is just around the India and where we are and kind of confidence around delivering this year. And then it's not in the report, but it's been referred to a couple of times. So I just want to just draw out a couple of the key points around where we are with all the guidance been dropping about the plan around. So I'll scroll there. So firstly, just in terms of the in-year and where we are, and to build a little bit on the report, key lines I'd normally draw out, I'll just step through. So in terms of headline positions, clearly year-to-date revenue is on plan, which is great, and we've been there since month 4. A little bit of pressure early on due to the additional surgery capacity that we had over the start of the year. And as you've been hearing from Scott and others, you know, that has been largely facilitated through partnership working across the system to allow us to have an appropriate response to the urgent. So revenue on track. Below that, the key areas that as a national team and regional team that are looked at in detail are on the cover sheet. But first of all, temporary staffing, which I draw out. We're doing really well on temporary staffing, and it's been a process we've been working on for the last 2 years before that, as we came out to COVID. What you'll see is depth there, though, is that we're slightly ahead on the agency part, and we have a bit of a pressure on the bank part. That's actually a fairly common position across NHS organisations. It's not to say that's fine. We're aware of that. Some of that swap out from expensive agency into bank. Clearly, there's an element there around about actually how we work with our services to drive down that over number. And with a kind of a nod towards next year, that becomes another key part of what we've been asked to do for next year. So the headline expectations dropping out of the planning framework for next year is further reduction of agency by 30% and a reduction on bank of 10% on return. So those will form part of a key part of our plan, and that's all part of the NHS ambition to have no agency in 3 years from now and just be using our staff and an element of bank. So really good work on that, and particularly thanks to Natalie and Ops leadership around that over the recent term, and Matthew in the past actually. Secondly, behind temporary staffing, then clearly efficiencies. Again, huge impact, huge importance for all NHS organisations. And again, we're doing really well in year. We've got a very tough plan to deliver, just over 13 million pounds, and we're on track against that. As you'll see, year to date, we're slightly ahead of where we need to be. We've talked about a number of those. Temporary staffing is part of that. UEC capacity, inappropriate out of area placements, all going very well. And I'll just reflect back actually, whilst the previous comment discussion was about, oh crikey, the streak's been broken. Actually, the streak's phenomenal. It's about having sustainable delivery, and there will be occasional patients that need to have to be placed out. Trying to minimise that. Of course, that later. Quite a few other things, obviously, in our plan and our programme for the year, but they are going well. I will just call out here phenomenal work from across the trust on the reduction of corporate costs, which has been a really difficult thing to get through, but a really necessary thing to do. And that's everyone across the trust sharing their load of challenge, and some really good progress there. So we're well on track to deliver the circa 10% reduction with the impact out of. Just then to kind of draw together the final bits on the year and the look forward. So we are well positioned at the moment. We have clearly some risks for delivery for the not least how we get through these limited pressures and so forth. But the team have responded phenomenally well around that, and there's nothing at the moment that's standing as additional risk that say additional books under due pressure. So keep the focus on the areas we are. Just the final bit then on the in-year to draw out is really the capital programme. Again, you'll see it's slightly behind at point of reporting. However, that's mainly due to the fact large schemes that are due to come on later in the year. Very confident those will happen. We've had some full reviews. We're expected to deliver our full capital programme by the end of the year. We've already had mention earlier of my youth work that was planned, which was completed. The other one that's just completing is the work on Stonebone first floor, which has been another significant scheme. Will have large benefits for both our patients and our staff as well. So then, just very briefly, just to draw out the planning part, the look ahead. We've had a discussion as board at the last meeting around how that looks in terms of scale of the challenge. It's just to draw out really that whilst we're receiving all the planning documents in, there's been significant information and allocations. There is now an awful lot to pull together to meet the first submission deadline, which is 17th of December, and then have a process of validation and checking through and finalising. We are looking to have 3-year revenue plans together. Scott's alluded to some of the parts that need to feature in that, which is around the investment programme for some services over that period. Obviously, a lot of internal work. It'd be remiss of me not to say that the finances do look challenging for that period. We will be having to deliver a minimum of 4% current efficiencies each year, which, as we know from this year, is not easy, but the teams are focused on that, and there are opportunities to do that. So we're going to need to work through that. Not a lot more to say on that. We'll obviously keep all updated, and I think the key government points for us will be the January cycle, and then the final position as we get into the March part. And I'll pause there for questions.
Multiple hands. I think it was Colin Sue on me.
Not particularly on this specific question around a comment you made about agency. So the plan is to reduce agency gradually until it sees success, which seems very laudable given the profits and so on that these organisations make. But it seems to me they must exist for a reason. Perhaps they've overgrown, but there must be a sort of latent demand within the system for the flexibility that agency gives us. So is there an unforeseen circumstance or an unmitigated risk that we should be thinking about if agency does diminish to that extent?
Right, well, I suppose that's probably reflection on where the NHS as a whole has found itself, particularly since pandemic, but we're, clearly quite a lot of work around agency prior to that as well. I'll let colleagues come in terms of where we get to. Actually, this is national policy to get to elimination of agency. This is new within guidance. That is the national policy. It's something we've been working at for a while. Clearly, we do balance that in terms of need, and all organisations have been asked to do that. Big backdrop to that, I can see that's coming in, is really about where we've come from, where we've had, as we know, significant problems around recruitment and retention, which largely is moving forward positively, but still quite some way to go. And on the back of the pandemic, there was a huge explosion that way of the use of temporary staffing, and this is just around NHS responding to that. I don't know if this.
Yeah, absolutely. So if you asked me a year ago, did I think we could stop Thornbury use? I sat here with, we'll try our very hardest. We've stopped it. We haven't used any Thornbury since 1st of April. That felt absolutely unimaginable this time last year. October last year, we spent £500,000 on agency. This October this year, just over 100,000. So we have hugely reduced our reliance on agency. The next step is about that elimination of band 2 and 3s. We're almost there. Confident we're going to be there by January. The flexibility bit is about a reliance on a certain way of working. So if we can be more flexible in relation to who are we bringing on to NHSP, and I have to say our NHSP partners are incredible at working with us to give us that increased flexibility. If we look at our workforce in a different way, I think we can minimise the risk. Can I sit here and ever say that we wouldn't ever approve an agency shift based on clinical risk? No, I think that's the right thing to say for me, because patient safety will come first. But do I think we can absolutely get there? Yes, I do.
And just to draw on that, our largest risk remaining, and which will be the bigger challenge next year, John might want to add, is our medical spend on agency, which now kind of set to what we spend. So that's the bit that's now coming in. That's John will come in, but it's not related to hard to fill roles.
So, did you want to add anything, John? Or?
No, I think with the medical agency, there's been quite a lot of work done over the past couple of years to reduce it. So it has reduced, and it's a target of our yearly plans. Challenge we have is that there are some hard to recruit posts, especially in community mental health services, we've also had some long-term sickness this year, which we are recovering from at the moment. I think going forward, next year we would really need to be looking at different examples of good practice from elsewhere and trying to get more, possibly make these unattractive roles more attractive by combining them with university roles and things like that. So we've got some joint posts with University of Birmingham and University of Worcester, which we are being advertised. So those are the ways we are anticipating recruiting medics. But you know, I was going to come on to that in the next paper. We do recruit by word of mouth, and you know, for example, in our acute inpatient areas where we had all 5 agency consultants, we now have 1 agency consultant, rest 4 substantive consultants who have come from neighbouring trusts. So there's always the ongoing, apart from advertising, there's always the kind of networking and encouraging people to go to an organisation that happens.
So 2 unrelated questions, and the first one is a little bit half-baked. And I'm hoping that Natalie will help me, because I don't think it's a Robert-style question at all. It goes back. Well, it goes back to the Q&S when we talked about vacancy rates, and that there was a disparity between one set of and the financial.
Yeah.
And I just wondered if you could fill in where we're at on that.
Yeah. So this is about sometimes. So we've got these hard pockets to fill. So medics is one of them. Registered mental health nurses is another. We've got some gaps in children and young people. How do we know that our vacancy rates are accurate? We're working really hard together to make sure. So what we know is the funded establishment's correct. So that's been sorted. But we'll always have posts that are either out to recruitment or they're within recruitment. Some posts with very senior clinicians can take 3 to 6 months for somebody to work through a notice period and join us. So those posts will look like a vacancy on our current system, but we know that they are not because they've been recruited to. And that's the bit we're working on, isn't it? The dashboard that Sam's developing.
Yeah, so we're looking at, and we have kind of trialled it in a couple of areas, looking at how we bring our recruitment data in to also take into account, so it shows what the true vacancies are rather than what's in the pipeline. So I think for this month, the people and culture, within the vacancy numbers that were there was something like 25 people actually coming through the recruitment process. So we're almost there, and it's just some kind of technical system issues of getting there, but that's what we're looking at. So we triangulate all of that data and have a much more accurate figure then of what the vacancies that are actually available to recruit into.
And will that have a positive impact on our bank and agency spend because we won't be filling in gaps?
It will give us better grip. Yeah.
Right. So my unrelated question, which you will like this question, is the space audit.
Yes.
Is that giving us any thoughts that there are some productivity bonuses?
So I was going to touch on it in the estate strategy part. So the estates utilisation exercise we've done, I'll just draw here. Short answer, yes, it will give us some opportunities that will be part of our 3-year plan going forward, will be around better utilisation of our estate, and there's some financial opportunities there as well as opportunities for. So yes. Good.
Yeah, thank you, Rob. Can I just ask you about efficiency? Because you talked about, it's really good to see that we're on track and that we are actually delivering above plan. But then you mentioned about 1.8 million being on non-recurring basis, that we might, it would affect or impact our underlying position if it's not done recurrently. So, and then you've talked about, forward plans deliver another %. So that kind of brings me to the question of how confident are we? Have we started planning on how we can deliver some of this currently? And also, how do we then do that and also get the 4% without actually affecting the quality of care that we're delivering?
So quite a few bits there. In terms of the 1.8, yes, we have a difference between the time of the report. We have a full plan for that for this year. There are some national directives around how we are meant to account for and plan against non-recurrent delivery, which we touched on at the board last time, and as we go forward. In terms of our financial position and where that leaves us, and as we look forward, I suppose the first thing I'd say is we're very unusual as a trust that we have largely always delivered currently against our efficiency plan. Actually, 1.8 million of our 13 and a bit plan is proportionate. It's very low compared to other organisations. However, we do have that as a carry forward first call on what we need to do, so it does make our overall scale of the challenge of next year larger. The big point I would draw out, which I suppose at this stage I just agree with you on, is that we need to plan to deliver 4% or that order, potentially more, for those future years recurrently. If you don't deliver it recurrently, one-off, you'll have to do it the year after. So the starting point will be looking for current savings. There's likely to be an element in there of effectively an assessment of we will always deliver a small element non-recurrently, so effectively we'll put that in the plan. Then that is just about having a robust plan for as a board signed up to. In terms of the QIA, the quality impact part, we have a very robust process around that, which I'm sure that's a big job. We're happy to talk to you outside, but there is full testing of plans. Unless they pass that process, they're not enacted in yet. Thank you.
Further questions? I think it's clear that the financial envelope that we're being asked to live in is a really tight one. And it can at first appear that actually we're making some compromises. Clearly, we'll have to make some tough decisions. But, from what I've seen and conversations that I've had outside of this board meeting, it's very clear we're not undermining patient quality or patient care. What we are doing is making decisions about how we work, how we transform, how we innovate in order to cope and manage within our envelopes. That's really important. What I'd urge all committees to do as we go forward is continue to make sure that we are looking through that lens every time we look at papers that are coming our way and decisions we're making, because it is important that we not only use that lens to look through, but demonstrate that we're doing so.
Yeah, I would just add to that point, because I think, and this is probably why you're saying it, but for those who are familiar, hopefully you are all familiar, but if you're not all familiar with the KARK review, I would encourage people to have a look at that online, KARK, which was the findings from some of the from some of the more significant failings the NHS has had. But a key point in the learning was that in some of those organisations, finance over-dominated decision making and quality and clinical lost their voice. And I absolutely don't think we're in that place. But I think the findings of the KARK review are a good reminder for all of us as board level members to refresh our memory of findings of that important review.
Now, we are slightly behind time, but not massively. If I can fast forward a break now, and then perhaps we'll continue with the rest of the agenda. Do Parth and Fiona. Parth, Fiona, if you need to pause or whatever you need to do at your end, I'll let you do so. And can we come back in 10 minutes if that's okay?
Could I ask a colleague in the room to mute the microphone, please?
That'll be Scott. We'll try and find the microphone.
Oh, is it on it's on a laptop, is that?
It's on the screen here. Fiona and Parth, you can get us started again in a sec. Hear that?
Okay, yeah, we are good to go. I will stop sharing.
Are we good to carry on, Fiona?
Yes, whenever you're ready.
Thanks, Pete. Okay, good. Thank you, folks, for your speedy return. That's good. Naomi, priority programs.
Yeah.
Focusing on a little bit of a deep dive on length of stay in mental health intervention.
So I'm just going to give a brief overview and then I'll hand over to John to do the length of stay. So the paper shows the 13 trust priority programmes. It shows the assurance level and also where that's moved from the previous report. So all of the programmes and assurances have been discussed and approved at the relevant subcommittees. The only one I wanted to particularly pull out was the EDIE programme, because the report shows that it's actually gone from a level 4 assurance to a level 2 this time. So the reason for that is we've had a look and revised the priorities and made sure that all of those are aligned to the high impact actions, and actually we're focusing on the right areas. We're pulling out the real priorities initially as inclusive recruitment and experience of bullying and harassment. So we've got quite an ambitious action plan. I think we've acknowledged that there's more we need to do in this area. So we've got a good action plan, and we're looking at our measurement of impacts around these areas and how we can move it forward. So that is why there's a reduction in assurance level, because we've effectively set new and revised priorities. So I'll take any questions, otherwise I'll hand over to John for the focus.
Some questions now for you. My only comment on the EDI programme would be that I think we've set the bar high now. And we've had a good look at it from what I can see, and we've decided to set the bar as high as we can. And I think that's absolutely the right thing to do. Clearly, that means there's a gap between where we are now and the work we'd like to do to get us to the standard we need to be at. But that's well understood from what I understand.
Yeah.
The question I have is for the People and Culture Committee, whether we're now confident that the programmes and work we need to get done to get us to 3 and then back to 4 and so on are now ready.
Yeah, I think we are. I think we've got a clear plan of how to get there. I think we've got clear responsibility, and that actually it can't just sit within one team. So that we've got leads for each of those pieces of work, and I think there's much more alignment across the subcommittees.
We had quite a detailed discussion at committee about it, and we're satisfied that we've got the right focus now. Yeah. But it does come with that dip in the assurance level.
Thank you. Okay, well, let's take time to get under the skin of the length of stay in mental health inpatient. John.
Thank you, Chair. So there are some slides attached which I will take as read, but what I want to present on is some of my reflections of this programme as SRO. And what I'm going to touch upon is 3 things. One is acute mental health, and when we talk about acute mental health, I'm talking about the 3 acute wards, 1 at Stonebrook, 2 at Elgar, and 1 PQ, but also associated services like the crisis and home treatment team and the neighborhood mental health team, etc. We're talking about an improvement program, and I'll be talking about the recovery plan. So over the last 2 to 3 years, we've been undertaking some extensive improvement program on our acute mental health services. We've been addressing some variability and improving quality across the acute pathway. And we've spent quite a bit of investment in our structures. So you'll be aware that we eliminated dormitories across all our acute wards. We improved the therapeutic spaces. We did quite a bit of investment in terms of digital. We implemented electronic prescribing and now have a new electronic patient record. We also undertook some reorganization of providing in-house pharmacy services for our wards as well. And we've been doing some extensive work around workforce, skill mix, etc. And as I mentioned before, an example is the successful recruitment of consultants into patient. Natalie has been doing the same, and Scott's been doing the same around the nursing AHP workforce skill mix, but also a newly formed operational leadership group within the SDU. We were also looking at processes in terms of patient flow, the patient journey, and how we can improve the process. However, we had some problems with patient flow across our inpatient areas, and to the extent that Finance and Performance Committee asked for a recovery plan in terms of reducing that. So when this came about, I think the Associate Director of the SDU was tasked with the recovery plan. We at the improvement program thought that would be duplicating work if we are working separately on the recovery plan and separately on the improvement program. So what we decided to do was to subsume the recovery plan and accelerate that piece of work as part of the wider improvement program that we were undertaking in the acute services. So we started this. This is the second recovery plan, which we followed a different methodology. I know there was a previous recovery plan which was working. And we started this piece of work in January this year with a planned end date of October, the end of October. So one of the things we picked up as an assessment of the issues that were happening with the previous recovery plan was that it did not have a systems approach. It was looking at very specific parts of the pathway and just targeting that. For example, the main focus was on targeting people who were staying longer than necessary in patient areas. So that wasn't, I think, a sustainable approach in terms of improvement, because it looked at a very specific problem and tried to resolve that. Also, the planning around the recovery plan, the previous recovery plan, was more reactive rather than proactive. So it was more of a Friday evening kind of reactive planning rather than a proactive planning. But also, there was quite a lot of variability in clinical and operational practices across the wards and across Herefordshire and Worcestershire, which weren't particularly being addressed and was leading to quite a lot of friction between teams and relationship issues, especially between operational and clinical staff. So what we did was to take a new approach. We essentially took a quality improvement approach, brought people together to co-produce what was our quality improvement recovery plan. We took a very systems approach. I think there was a temptation to look at a problem and just solve that problem. But we took a much wider approach in bringing neighborhood mental health teams, crisis support treatment team, the inpatient teams, and the specialist teams together to look at how we can improve the entire patient pathway. We also took, we used the user tools that were available to us, and using that made it very obvious to staff about where the bottlenecks were and where the issues were, because it highlighted areas of a patient flow which people didn't think were a problem, but was a problem. So that using the user tools and methodology really helped with a much more systematic approach to addressing issues. We also set up a governance process which started off with a weekly or a twice weekly meeting between myself, the Associate Director of the SDU, and the Program Management Office, just to keep on track of what was happening with the steering group and how actions were being delivered. Then obviously we had the improvement steering group, which reported to the mental health improvement program board, which reports to program management. Change ideas. This was one of the key things. So we were very clear that the primary drivers were set. So, it was about looking at patients coming in. It was about looking at patients staying in the wards, and looking at patients and how patients were discharged back into the community. But the secondary drivers and the change ideas came entirely from the staff who co-produced this. And some of the change ideas worked really well. Some of them did not work. And that was the whole point of change ideas, to try and test them. But some of the things which came about, like the 7-day bed management, level 1 and level 2 InReach, having a daily SITREP. Believe it or not, there wasn't a SITREP to manage youth mental health flow. So providing that, making that more visible to operations and clinical leaders on a daily basis to have an oversight, but some of the change ideas which came from the group. Now, one of the principles, obviously the methodology is a quality improvement methodology, but the underlying principle of this program of work was adopted from the clinical strategy, which is about being clinically led and management and corporate enabled. And what I mean by this is led by clinical values and what's most important to patients and our staff. So this changed the narrative from you are not doing enough to improve patient care. You are not doing this, you're not doing that, you're not discharging quickly enough, etc., to how can I help you? So how can I help? And I think that kind of approach really helped. Some of the examples was they wanted an executive-led panel to work through some of the complexities for individuals who were staying longer. And we facilitated that, and that enabled quite a lot of the long stayers to be discharged. We had weekly MAID events put in, which were clinically chaired, which also helped with some of the conversation discussions around patient flow. And that really changed the narrative from actually, you know best what to do clinically, how can I help? And that kind of helped. You go in with a mentality as a leader and a manager of unblocking barriers rather than take a very punitive approach in terms of what was happening. So that really helped us, and I think there was quite a lot of engagement with the teams on an ongoing basis. And it hasn't been without problems, but I think eventually everyone kind of started working towards one common purpose. But also the dramatic shift that happened was the kind of joint working across Herefordshire and Worcestershire, looking at one acute pathway across and standardizing much of the clinical and operational processes we had across the two places. So at the time of writing, and I think we discussed this before, we went with 175 days of not having an out of area. And I think we are at the moment seen as an exemplar in the region. We have been able to share all our information with other trusts regionally. We've shared our driver diagrams and all the tools we have used. And our team has been able to go and present last month in Leicester at the Midlands Learning Improvement Network event around this. So as per plan, the recovery plan as such being held by the improvement ended on the 31st of October. And as per plan, we have handed this back to the SDU leadership to try and test the sustainability of what has been learned over the last 10 months. And the idea is to test the sustainability and provide a closure report to PMB by PMB and FNB by March 2026. So I think I could sense some disappointment amongst board members around, breaking that record over the weekend. However, I would urge you not to be disappointed, but look at this as a learning opportunity, because that's the principle we've been working with them, that it's okay, but what can you learn to improve? Because our disappointment really permeates through these walls and reaches those teams. So I would look at this as a learning opportunity, because that's the whole purpose of testing this, and how the SDU leadership take ownership, how they are empowered to learn and make this sustainable going forward. So I think personally, it has been a very satisfying experience for me to lead on this piece of work. And I think it's the SDUs have worked amazingly well. The ward teams and the neighborhood teams, the crisis teams have all been fantastic. And the program management office have been a fantastic enabler in this process. So I will end it there, Paige, if that's okay, and happy to take any questions.
Just an observation really, John. I think if you sense any disappointment, it's because it's an acknowledgement of all the hard work that's gone into it and feeling for everybody else, because it must have been very disappointing for them. So I don't think it should be seen particularly as criticism of the board. It's more a case of saying, we know how much you put into this, we know you're on the right track, but you know, it happened.
I have to say that I think Scott and I were on texting each other. I think it was a bit of an unusual circumstances. I think the learning lesson is we shouldn't go into a weekend with no beds. If we are, we should have contingency plans. But the situation over that weekend, I think we were actually accommodating for 3 inappropriate out of areas from elsewhere. So, you know, those are 3 beds which should have been free for us. So we are working with ICB to see whether we can badge it against that so that we are not actually seen as breaking the record.
We've had enough. Yeah.
It's looking for a technocratic fix.
I'm all in favour.
Good. Ellen.
No, I just really wanted to thank John for the deep dive today. I think that's been really helpful, really informative. And I think what you've done really beautifully is draw out the lessons learned for us as a board, because I think it is really important we apply the learning and the points you make about how the sort of the culture shift that you brought to the programme, which is really important as well in terms of clinically led, operationally enabled, and the leadership you've brought to it, which I want to thank you for. So it's how we can apply that into our programmes, which will be just as challenging next year. I think one thing that has worked well is having priority programmes with very clear governance and objectives. And I think that is a real credit to the trust, and that the delivery has been so strong. So, and I think just to sort of finish, we plan to, again, this is another slightly reframed report where we'll just provide the very high level summary, because we'll assume you're testing detail in committees, but we'll do a deep dive where we think there's something to draw out for the learning. And happy to take, if people are particularly would like to see an area have a deep dive, also happy to hear suggestions. We are a board who can select these priorities together of the things where we think actually I'd like to understand a bit more or get under the bonnet of that. So we'll select, but also very happy to hear thoughts if you would wish to put them in.
Yeah, thank you so much, John. John, this was really, really good too, because it just shows what you can achieve when you bring people together to actually think about what needs to be done, rather than us trying to decide for them what needs to be done. So it was really brilliant to see that, because I've seen that happen with my sister. Just bringing the teams together to think together and get the solution themselves and own it as well. I think that's absolutely amazing. It's actually quite a good testament to what can be done if we empower the teams to do. My only question to you actually is about, you mentioned in the report about the complex emotional needs pathway and the purposeful admission framework. Said both are still in progress. I know this has been a few weeks ago. Are they still in progress, and do we have the timeline when? Because obviously this whole is all dependent on it being fully embedded. So,
yeah. So like I mentioned, the improvement program is a wider piece of work which will carry on to March 2026. It needs to go further than that. We will very much a quality improvement approach. These change ideas have cropped up at different stages of the last 10 months. So right now, there's some work being undertaken to improve the crisis and home treatment team across Herefordshire. The same thing with complex emotional needs as well. So these pieces of work, or associated pieces of work, will carry on. And it's difficult to put a time frame on it because I specifically asked them that we need to complete the improvement program in total by March 2026. Okay, so that's what we are working towards.
Sorry, my second question is on the length of stay. So we've now looked at getting our teams involved in creating the solution. Are we looking at, or have we started doing, I guess we might have, in terms of the long stay patients as well, getting their experience and using that to actually craft how we work on length of stay?
Yes, absolutely. So through this program of work, we obviously use patient feedback to inform our work. We also have 2 patient partners on our program board with lived experience who challenge and everything that we do in a way from their perspective. With regards to length of stay, it's a rough calculation it's a rough calculation that we have a 50 acute beds, so we can only manage with that if we have a length of stay of 35, an average length of stay of 35. So we do have long stays, and as you can see, there's some data which has shown that that's come down. But if you look much closer into the long stayers, or at least at the beginning of the program, a lot of them, I would say, shouldn't be in an acute. They should be in a level 2 rehabilitation ward. And I think that's one of the change ideas which came about, where level 2 commissioning managers and level 1 commissioning managers engage into the wards. So they come and visit the wards once or twice a week and actively seek out referrals and patients who may fit the criteria. Whereas in the past, these individuals were just having level 2 rehab or an acute ward. That was what was happening. So that in-reach helps with identifying earlier on who might be suitable for this type of beds. So that's one thing. The other thing is the usual delays due to placement availability and things like that. But again, we've got a very good working relationship with our partners to enable that process as well.
I agree that this is an exemplar of a really good approach to solving a broad solution in a different way through collaboration. And I'm piggybacking on Ellen's comment, Penny, because you said, I think your words were, we need to be sure we're doing this. And how can we be sure that this is the way we do things here in this trust, as opposed to having a format, but then other people do it their own way?
Yeah, really good question. I mean, my reflection is partly by doing exactly what we're doing now, which is socialising with yourselves, with our senior leadership, with sharing the learning. I think our program, I have been really impressed since I've joined with our programme management board approach. I think it's very robust, and there is that opportunity for programmes to sort of come together and share the learning. So and us obviously as leaders taking that, this is the way that we want to work going forwards and taking the learning ourselves. So I think that might not sound like a very processy way of doing it, but I think this is the way that we're learning works, and we can evidence delivery, and that through those mechanisms, that is how we will pick it up, and as well as our QSAR training and so on.
I think one of the advantages we have is our hero trained. So I've used them extensively to push that methodology with the.
Sorry, Sue, beg your pardon.
Well, I mean, I've also welcomed the opportunity to have a deep dive sort of explanation in the board meeting, because that's been really interesting. Yeah. And I suppose where that would also be interesting, either at board level or at QNS, is hearing about the same approach to capacity and to consent, which, you know, when we've done external audits, or internal audits, we've said we could be better on this, but hearing about how you could use that clinical approach, which is operationally enabled, to move those dials.
If there's no more questions or comments, thank you, John. I think this bit is a really brilliant evolution in our agenda, how we look at our priority programs, but also, as Ellen said, focusing on on certain areas. Clearly, the volume of inquiry suggests that we should perhaps allocate a bit more time next time to this section. It's going to be really, really useful. Thank you. Okay, Ellen, over to you, the BAF and the risk registers.
And speaking of time, I'm very happy to take very little time on this item unless people have got a lot they want to say. I just wanted to note that this, like a number of our reports, is something that we're going to do a bit of a refresh on. We haven't got so far on this one yet, and that's because not because we haven't paid attention to it, but because when we've gone back to the source material, to the risk register, we have identified some improvement opportunities around the way we're recording risk. There's also a really practical realignment job that needs to be done around, obviously, with the executive portfolios changing. Unfortunately, the digital system we use doesn't seem to allow you to reallocate. You have to shut down and reopen and revise, which is giving us some reflection about whether the digital system we have that is there to help us is perhaps helping us as much as it might. But we have a colleague who's very expert in Ulysses who's doing some work to support us. So we're going to be undertaking that over the next month or so. We're doing a deep dive. Each of the execs is taking a lead on having a deep dive into the risks that sit alongside their own portfolios, and then we will look to refresh the BAF. And the other point is that, of course, we have the interviews tomorrow, actually, for our person who will take a lead on this going forward. So I'm obviously happy to take any specific questions, but I just wanted to share really more kind of background work that we're doing to improve our risk management processes and our BAF reporting.
I don't have a question, it's an ask really. I mean, it's brilliant to see and hear all the work that's going into, you know, making sure that we are all clear about what the priority programmes and the NOF metrics and how they align. Brilliant. My concern really is sitting in committees, we've had a number of issues that have come left field. And I just, you know, I hope that in all this work that we're doing, we clarify and we are mindful of whether at SDU level, issues are being escalated consistently and on time. Because that's the bit where we continue to see odd things flagging up.
Yeah, and I mean, again, maybe this is something we can take offline and have a bit more of a deep dive into, because I think case studies are really helpful for us to think through how we can do this as well as we can. And obviously we've been doing the development work around the integrated governance. And I know Scott's probably bursting with ideas that he'd like to share, although I think time won't permit it right now, because this is something actually we've been talking about a lot, and how we do that really well and support leaders at that level of our organisation do this really well, because we actually have relatively more junior managers who carry a lot of broad responsibilities. So I think how we can systematically make that easier for people, help with the reporting at that level, are our systems fit for purpose, is something that we as an executive team have been reflecting on quite deeply over the last kind of few weeks as we're starting to get across our briefs and understand the risks we're recording. So I think I'd be very keen to pick up with you, Vina, on some of the specific examples, because they may give us more insight. But just to hear that that is something that we're very much reflecting on ourselves and how we can improve on what has been done already to improve our reports. And Scott, you'll have to hold your ideas. I could talk on this topic. 10 minutes. I know, but we're so. I'm like really mindful. We're like 45 minutes behind or something. Although we've had the break, haven't we? So yeah.
And also, I mean, outside of this, we should definitely pick up with you, Scott, because you can see you're bursting with thoughts and ideas. Should capture those. Yeah, absolutely. Good. Okay. Thank you. We'll go on to the assurance and the committee reports. Can I suggest here, the reports are there for everybody to read and see, and I'm hoping everybody's done so already. Let's each of the chairs pick out what you might feel are the key moving parts and take any important questions and then we can move on. Is that okay? Great. On you, quality and safety.
Yeah, thank you, Chair. So this, like we said, if we take the report as read, we'd like to just bring to the board's visibility the areas that I think we need to be aware of. Number one is the under alert. We brought out the ADHD and ASD waiting list, but it's good to hear Scott talked about it earlier, so I'm not going to go into too much detail apart from saying that at committee, we had a detailed conversation about the fact that, yes, the waiting list is long, but there is concern about the data. So a data cleanse is started, and we're going to use that to prioritize based on clinical need. And because it's a system complex issue, we're looking forward to what's going to happen by December, you said, and hopefully we'll come back to committee in January for us to look at what has been decided. In the same frame, I'd like to bring forward under advice, we have the non-medical equipment and housing adaptation. We need to be aware of that as well, because although we are completing the assessments in good time, this is out with the trust, because fortunately, the decisions and the provision lie with system partners. But we were assured that there is now a system-wide discussion going on to resolve this, because obviously this is impacting our flow and independence of the patients. And we resolve. The other bit I'd like to bring to our attention is the safeguarding bit. That's on the shore. We discussed about the demand and the complexity continuing to rise, particularly around domestic abuse and MARAC referrals. So it originally used to be about 40 a month, but now it's about 100 a month. So there is significant pressure on the team, but they are continuing to do well around it. And also, they've also noted that prevailing concerns, especially around young children, is rising because of online content. But after discussion, we agreed that they are continuing to deliver safely, and we will continue to maintain focus on that, and we maintain the assurance at level 5. And the last one I want to talk about is the accessibility working group. It's only just started. We approved the test of reference, and we're hoping that that would carry on improving. Now, sorry, there's one more. Under health inequalities, PCREF, we had a detailed discussion about that. We felt that it hadn't progressed and it hasn't been sustained to the level that we expected. So hopefully we're going to see it coming back in January to see if that needs to be added onto our risk register, because 2 years on, we should have really progressed that way. We weren't assured that that happened. And we have the document that's been attached about research and development, which is a huge achievement at 7. So we have to celebrate the team for all the hard work that they've done. So we saw some real good, strong assurance in some areas, and the others where we hadn't. So that they are coming back in January. Thank you.
Thank you. Any questions for me? Hey, Vina.
Thank you. So obviously this was our first committee meeting using the revised agenda explicitly aligned to the NOF. As such, we focused on 3 metrics where the trust is most exposed: staff engagement, sickness absence, freedom to speak up. And to be candid, people and culture has been the lowest scoring oversight domain in this past quarter. And committee is treating that as a clear instruction to sharpen our focus on those specific areas. I'm going to take the report as read, but just to pick out the most important points. Obviously, in terms of engagement, the staff survey is currently live, and it goes without saying that the level of engagement with that, and see how people feel they want to respond, will be critical if we're to see any movement in those NOF metric scores. Sickness has risen again, and we agreed that we need a credible recovery plan based on seasonal patterns and peer benchmarking. So that will be coming back to committee early next year. In relation to freedom to speak up, more staff than ever are coming forward, which is positive, but we're still seeing inconsistencies in confidence across the teams. we've talked about the attraction, the workforce figures already, and the fact that our data accuracy has been improved. We've noted really good progress in relation to culture and leadership, but we heard really clearly that leaders need more headspace to embed the behaviours and practices. As Naomi mentioned earlier, EDI is one of our key risks, and as such, the EDI programme has been reset to focus on those two essential areas, inclusive recruitment and staff experience in relation to bullying and harassment. We really do feel that that's the right focus, but it does mean that assurance has dipped temporarily, just to embed that approach. And then finally, I want to highlight the mammoth effort that's gone into finalising this huge suite of people policies, which have been brought through the committee. It was a massive piece of work across multiple teams, and discipline shown in getting those policies reviewed, updated, approved. I mean, that gives us a much stronger and consistent governance foundation going forward. So I guess to conclude, we know where the workforce risks are. We're now aligned and focused on tackling them. Sickness, engagement, EDI are our biggest challenges, along with enabling people to speak up and ensuring that there is an effective follow through. So now I guess it's about having the right grip, the right recovery plans in place, and the right momentum to drive improvement.
Thank you, Nina. Any questions or comments? Yeah. Thank you. Finance performance, that would be me. Again, report, I will assume everybody's had an opportunity to read and digest that. There's nothing really to call out other than to stress the fact that we've now completed all of the management actions in respect to the internal audit, I believe. Colin will tell me otherwise, I'm sure. And the last one was the IT business continuity internal assurance audit, which was done satisfactorily without any action. So that's good. And on the Assure side of things, really importantly, two very important reviews. Strategy went through the estates and finance strategy, both very comfortable levels of assurance. So very grateful for those that have been working very hard to deliver those. I know that we'll come back to estate strategy later on in this meeting. I'll take any questions if there are any. Common theme, as you saw, is the NOF. Continues to be a bit of an umbrella that we need to just recognise, and I'm grateful for all the committees to have taken and lifted the NOF right to the top of the agenda and making sure that we're addressing those and talking about those things. Thank you. Okay, Colin, Audit Committee.
Yeah, I could be brief on this also, Chair. Thanks. A couple of things I wanted to raise. One is that we had a retrospect at the performance of the trust responding report of the external auditor, and the good news was that feeling was that it was a good process from both sides. We did things as well as we could, and the external expressed satisfaction. So I think that's a well done to Robert and his team, and I suppose reluctantly grateful thanks to the external auditors. There was one issue that came out of the external audit, which will be familiar with, I'm sure, was the question of the treatment of the costs of Rio, and the external auditors expressed some concern that they might have been revenue costs rather than capital. I think the current view, recently Robert, was that a lot of work had been done, and it seemed to be that we adopted the correct accounting treatment. But we certainly had a warning across our bows about being very careful going forward. And I know from other sources, if it's a national issue, in terms of how trusts can follow the mandate to increase their digitalisation when you can't capitalise it. So I think that's something we'll keep a watchful eye on. And the other thing I wanted to mention was that we did have a limited assurance from the internal auditors of business continuity that you usually find that's committee, and I can confirm I have no further issues that need to be concerned about.
Thank you. Thanks, Colin.
Just on the Rio, we've done a full look back exercise on that, and Colin, beware, we're engaging with Deloitte. That's on the agenda for December to go through
Chatting with a few chairs and others at the providers conference last week, there's been some interesting and varied treatment of SaaS type products by different trusts, depending upon who their audit is. So it's quite interesting.
It's a national issue.
Yeah. I would hope that we're taking as robust that attitude we possibly can. I'm sure we do. Cool, thank you. Thanks for all those bits. This is a really welcome bit of the agenda, and we should spend a bit of time enjoying this section, I'm sure, which is Ellen's first 100-day reflections. And if you want to follow that up just immediately with the trust strategy, which we're all being asked to approve, by the way. So just for you to note. Okay, Ellen.
Yes, thank you. Wait for Diligent to load.
I think you look great in a high vibe, by the way. Yeah.
So when I said it would be really great to use some actual photos of me, I was particularly thrilled to see that one going in.
Just if anybody hasn't.
Yeah, it's she's just showing it in love. I mean, really a brilliant one. One of the things actually of being a chief exec is I've learned you have to develop quite a thick skin about your photo being on lots of things. So, but no, actually, thank you, Beej, for that introduction. And obviously, we slightly stretched the definition of the first 100 days because I have now been in post for just over 6 months, which has really flown by. And so, yes, and in that time, I have obviously been taking a lot of time to visit services, talk to people, listen, talk to our partners. And I must say, it has been obviously with some of the things that we might set to one side that have been not so happy parts of my first 6 months. Overall, I have found it a hugely enjoyable time, and actually I've loved my first 6 months with the organisation, and a huge privilege to have this role. So in that time, I think I have learned, I will not have obviously heard from everybody, but I think I've heard enough to kind of get a reasonably good picture of where I think we are and how it feels to be part of our organisation. And I hope that board will find the reflections I've shared helpful, and how we've then, you'll see as we really woven that into the trust strategy as well, alongside lots of other inputs as well, of course. So I've divided my short report into 3 main sections. So the first one is about our people, our culture and our values. So in terms of the strong positives, actually, I've heard from lots of people across our trust that our cares values feel really meaningful and relevant. And there's been some great work done already to improve our shared culture. And some of those things are really impressive. So I think our homegrown, clinician-led compassionate leadership training, which we will all be taking advantage of again, some input from those colleagues this afternoon, is a really fantastic thing and quite unique for trusts to grow its own in that way. And I can see the efforts have really begun to shift how it can feel to work here. I think where I would reflect the kind of next stage lies is moving on from kind of training sessions, improvement initiatives, and really seeing these ideals embedded in the way we work and treat each other every day, day in, day out. And some of the reflections I have on that in terms of what helps to continue to build on the great work done around our culture is that actually some of it goes to our the sort of heart of our policies, procedures, the way we work, the kind of nuts and bolts of our organisation, really. So firstly, and actually you've referred to some of this just now, Vina, in your report, but some of our HR practices where we haven't maybe had the policies in the right place, we haven't always applied them consistently or fairly, things like the examples I heard from some colleagues around things like using repeated short-term contracts. We haven't eliminated that altogether, but like the young employee I met who was on her 5th fixed-term short contract, I don't think any of us would feel that's an acceptable experience for somebody working for us. And I don't think we would accept it for ourselves, actually. And so some of those things create really significant uncertainty for people and make it harder to feel like this organisation is truly compassionate. And so we have to keep improving our policies and making sure our line managers across the organisation feel confident and supported to apply them fairly and consistently. It's that experience at the kind of hard edge of our policies and procedures really can make a difference about how it feels to work here. And I think the team, Naomi, Vina, other colleagues in your department have done significant work to move that forward, but there are still things we can build on, like the work you did, Naomi, to identify the number of people we still have on fixed-term contracts, short-term contracts, things like that. And sometimes they will be appropriate, of course, but I'm not sure they are quite still to the scale which we have. And some of that is about decisions we need to take in the leadership space to enable roles to be confirmed and move forward. I think the next point is about change management processes. And I think since I've been here, I've seen examples that are really good and examples where it could be even better if we use that appreciative frame. And it is important that we listen, involve people and work together. And leaders need to be open and honest, even when it's difficult, to minimise anxiety. And again, I think there has been a lot of reflection on some examples of when that hasn't gone as well. And we've seen a great example recently in the Worcester City and Patients Long May It Continue of a really inclusive process. And I think things like the initiative around the toolkit for the change management policy, actually having an up-to-date policy and the training and support we give to people. And examples like the learning example that Natalie brought to SLT last time wasn't it, around doing a deep dive into the change process from the 0 to 19 service and having a really open and mature conversation about that kind of what went well here, what could we have learned from, what could be better, and actually sharing that lessons learned with everybody across the SLT. And I think using that learning frame helps us to do these things better. I think my next reflection is that decision making can continue to feel too far from where the work happens for many colleagues. And I think, again, we've got work going on around that, but things like the weekly message, the shadow SLT, which I have to say are a joy. We've had the first few sessions with them, and their feedback, I think, was very much valued by the SLT the first time we had that last time. Open forums, sharing key minutes, they're all parts of how we democratise governance and foster trust. And I think a next step for us is how we really test our decision-making layers and governance structures and think about, again, test ourselves. Is everything necessary? Is everything as close to the service as it could be? Are we clinically led with services in support, leadership and support? It will be a good next step and challenge to us in our and leadership goals. The next point is about cross-team collaboration, and I think breaking down silos, and I've called it sort of teams of talent, but across corporate and clinical functions, and things that are already underway, like the business partner model that Robert and others have worked on in information and HR. These are all ways we can start to build that kind of the teams of talent where we're working together across functions and we're not sitting in silos. Things like the triumvirate model. These are all good ways. And, you know, John talked about some really great collaborative working today from PMO, clinical leads working together. And these are the sorts of things we need to really encourage as we move forward. And then my final point is that for many of our colleagues, and I've sat next to clinical colleagues wrestling with some of our systems, the administrative burden can be really high, and our digital systems do not always serve us as well as they could. So I've sat next to a colleague having to type in demographic information into 3 different forms after seeing a patient because it doesn't pull automatically, and we still have internal referrals and multiple forms. Now, I know I have quite a short patience spread, but I think I would be quite close to throwing my computer out of the window at that point if I had to do it myself. So I think a high priority improvement area for us is about how we can reduce daily frustrations, but also improve productivity. So I think we do have a significant potential, and it isn't just about wanting our trust to be a great place to work, which we do want, of course, but also it's about that really important point that improved morale directly correlates with empathetic patient care. I chose not to write about parking in this session. But you should all know that people do talk to me a lot about parking. And we'll be picking this up later in his report. But yeah, so that's my first domain. The second area is about our patients and about neighbourhood health. And I think my significant reflection here is that, and we are not unique in this, of course, that we, like many trusts, measure our performance by service, whereas our patients experience the system by their personal journey across multiple services. So if we truly want to put patients at the heart of everything we do, we need to start really pivoting to look at the data from the patient's viewpoint, identifying those people, we might call them high intensity users or people with a high need, people who live with complexity, but they are the people who interact with many of our services. And we will, I am sure, find, like most systems, that a very small proportion of our population use a large proportion of our services. And therefore the opportunity there about reducing repeated storytelling and handovers should improve patient satisfaction, but also use clinician time more carefully. Because every time we do ask a clinician to get that story from a patient, we're taking their time and they're typing it in and they're writing it down in those weighty records where we ask them to write down so much. And so I think there is a significant potential, and we might sometimes badge that as, we could call it productivity. I think that's a term that can switch people off. Really, it's about patient time, clinical time, valuing that and using it carefully. I think that is the word, and valuing what they both bring to the interaction. I think sometimes we don't think about the patient time that is used up. You know, I was thinking a little bit about that earlier with the dentistry example about our clinic is booked so that people just come and sit and wait. And I was curious about that. I don't know, maybe that is the best model, but these are things I think we need to ask ourselves. Is it the best for our patients? And then the point that I think flows on from that is about neighbourhood health models and working with, so being careful ourselves about our time and our multiple stories, our multiple interactions. But then if we multiply that across the same experience for people with primary care, with our primary care colleagues, with local authorities, with hospital trusts, voluntary sector, if we could integrate all of that, wow, it's such an opportunity. So let's start to try and join up some of the complex areas. The shared governance is always a challenge for us. Again, there's a digital piece in this about how much could our systems do more to help support integrated care that is wrapped around the patients. And I think we do bring a unique thing to our system around, we have the potential to be the connector. And I use the term here, ZEUS is the glue that holds things together, even when that's delivered across different teams and organisations. And thinking about how we can really have that outward looking mindset, working with the system and trying to think about our opportunity to help broker that, I think is a real place that we could position ourselves moving forward. And then my last piece, before I come to a close, is that I think in terms of our vision and looking forward, I think we have a huge amount to be proud of as an organisation. And I think when a trust is rated as requires improvement overall, it can be easy to fall into a place where we think, you know, that slide mindset of, well, everything needs work and everything needs improvement, and to lose some confidence. But I think it's now time to think about all the sort of amazing things we do have, to integrate that plan, to think about how we reframe our strategy, and to have a bit more confidence in the voice we bring into the system, and to use that as well to really recognise the unique perspective we bring for some of the most vulnerable people in our communities, particularly around mental health and learning disabilities, where as a trust we are the only voice. And if we don't advocate for those populations, then who is? So I think that is a really important thing for us. So I think for us in that space, it's about focusing on building relationships. The future is relational. It's not about sitting in a trust and having an inward perspective. It's about building relationships and looking at how we can take opportunities to foster that system development, but also, as I've noted here, to be curious and learn from others outside our trust into the county and beyond, counties and beyond. Even overseas, there are lots of places we can look for examples. I think embracing that renewed focus on our advocacy role and growing a greater sense of confidence in ourselves, both internally and externally, celebrating our successes and capabilities in the way that, John, you talked about going to present to the improvement network on a regional footprint. We have lots of things we could be sharing and thinking about how we become a bit more outward focused. So I think that then is how we it's got to be part of how we take our strategy forward. Obviously, we'll talk about the strategy in a moment. And the strategy is just the start. So from that, because obviously they're quite high level objectives, we need to think about the structured governance, the plan that sits underneath it. What does it look like to start to move forward on that with a clear roadmap and active engagement? That's it from me. Thank you for this.
Before we move on to the strategy, any questions for Ellen on her first 180 days?
I just spread it out, but I was having such a nice time.
No one was tempted to ask this, what your view was, but I probably should say well, like this. But I welcomed your comments across the board. I particularly liked the comments about taking a leadership position within the system and grasping the initiative and making things happen as a connector. I think that's ambition to have. How well positioned are we to do that, do you think?
So I think we are really well positioned, actually. And I think one of the things that we will need to reflect on as we start to frame our strategy and moving forward into that delivery plan is to what extent we may aim or wish to try and take advantage of some of the new frameworks coming out of the national planning guidance around things like New Foundation Trust, for example, and where those sorts of things could lead us in terms of, the potential opportunities around integrated health organisations. I think I'm not making a categoric statement on those opportunities, but I think those opportunities are there for us, should we wish to try and make that an ambition for our organisation. But sort of structures and contracts and other opportunities aside, what I would encourage us to do, and I hope the board would agree, is to be thinking about doing that with the values that we bring to the table, about the patient being at the heart of what we're trying to achieve, and that the opportunity we bring to be new in the system and help support partners to come together. I don't think it's about wanting to sort of lead or take over vast tranches of responsibility. I think organisations like ours bring a value set to the table that's about patients at the heart of what we do, working with the community and with community partners. And I think if we come at it with that perspective, we have something really valuable to bring.
Any other questions? I'm not going to repeat what I said right at the beginning of the meeting in respect of everybody on the exec team have done a cracking job. But I think with your stewardship, there's a real focus, a sense of energy around what we've got to get done. What you've outlined here resonates, as Colin said, I think it resonates with all of us. It all makes sense. It's very coherent. It's about the doing now. So the next 180 days report, I think we're waiting for. Good, thank you. You two doing a double act on the strategy?
Lead off, David?
Yeah. So the strategy document is attached. It has been through various different forums and received quite a bit of feedback. So what you see is kind of our latest version where that feedback has been taken into account. So I don't know, Ellen, if
yeah, so I mean, as it leads on really from what I've just shared, so we have identified 5 core priorities. We obviously outlined how that sits with our vision and values. I think what's important about this document, again, we've thought about it it's got to be something that people will pick up and want to read. Strategies are so often really long and therefore people don't read them. And it's also about stressing that it is a frame. So it isn't trying to be all of the delivery plan and everything else, but it is about trying to provide, I guess you might call it a bit of a North Star around, these are the core things we think are important for us in our organisation, in our system. And therefore, as we write our own objectives, as we think about our plans for the year ahead, how are we sitting them into these core objectives moving forward, strategic objectives moving forward? What we've also tried to do, and obviously you've done work with us on this yourself, so you'll be familiar with the areas, but is to explain what we think would be different. So that's sort of bit of that future visioning exercise. What would it feel like in our organisation for our patients and carers, for our people who work for us, and for our partners if we are able to deliver against these strategic goals? And I think that's important for us to kind of keep checking in with, are we moving forward in the right direction? So obviously people will have read the document, so I won't go through each of the 5 areas, but very happy to take questions on the strategy, or indeed what we plan to do over the sort of next few months as we crystallise this into a delivery plan.
Yeah, I thought it was very good, and I really liked page 8, which is the where will it be different in 2030. So the one where potentially it's not just us is when you talk about integrated, or we talk about integrated neighbourhood teams, healthcare and community services operating as one. Is that our community services, or is that thinking about our partners? Because this is what it's going to feel like for our partners.
Yes, exactly. So the vision is that, well, if you read what's in the 10-year plan and the direction of that travel, that does mean us, primary care, our partners in the hospitals trust for their services that will be out in the community and beyond, actually, into social care and so on, if we can pull this off. So I think, yeah, that is about all of us working together. Space.
Any other questions on the trust strategy? I think like every organisation who spends time and energy on strategy, it either gets left in a filing cabinet and then we. Oh, sorry, I beg your pardon. Did you?
No, it's not a question. It's just a strategy. What I loved about it is the readability.
That's important.
If you put it on, because nowadays we're being told reading age is just 9 to 13, and reading it was really simple to read and understandable, and putting in those what does good look like actually gives the reader the confidence that we are thinking about what they hope to get out. So thank you very much.
Well, I will take just a moment to say to pass on your thanks actually to Fee, who is not officially here but is online, and I hope listening, because Fee and I worked hard, but mostly Fee, over the last sort of, yes, that's good. Over the last few days, it was quite a frantic, and Naomi as well, it's quite a frantic to and fro. I was up in Manchester, and there was some midnight oil was burned to do the kind of work on the from a comms perspective on the language, and I think she really has done an incredible.
I was at the networking drinks by the conference that evening on our behalf, whilst you were in.
I was just going to say, just add to that point that also the team have produced some really good kind of manager guides, which will go alongside this. So it's almost little pocket guides that a manager can pull out and say, these are the main objectives, this is how it links to everything else, and some room for notes to discuss with teams. So there's some constantly literature with it.
I guess to add, just as you said about that accessibility, one thing I love about that, the Leaders Guide, is there's a part on it which we brought it to SLT, and you said you could laminate it and pop it up on the wall in the team or the ward, and then under each area you could put what you're doing. Yeah. So if all you've got a change idea, you can pop it on there. So it's really making the strategy come to life, and it means something to me, and that's what my team's doing, or that's what I can do. I thought it was a lovely addition.
that's exactly the point I was going to land, which is that this could very easily, dangerously be left in a drawer and forgotten about, and we'll see it again in 5 years and refresh it. Instead, actually, and it's incumbent on all of us in everything we do, whether that's committee business, whether that's conversations that we have when we do service visits or water cooler moments, whatever it is, I think it's important that we bring this strategy to life. Because actually then we won't need to talk about the strategy, it will just become how we work. Great stuff. Thank you very much for taking us through that and all the time and energy that everyone spent. Thank you. Where have we got to? John, we're on to mental health rehab redesign, please.
Right, thank you, Chair. So just like the acute mental health program, we've been undertaking an improvement program in our mental health rehabilitation services, and the work is essentially to modernize the mental health rehab offer for citizens of Hertfordshire and Worcestershire, and to align our services to the national guidance that's been recently published, but also following best practice. Because this involves re-looking at how we provide community rehab and hospital-based rehab services, we have been strictly following the NHS England major change process and have gone past the stage 1 gateway meeting, including the necessary updates to the health and oversight scrutiny committees in Hertfordshire and Worcestershire. We were supposed to have an options appraisal on the 1st of October and forward to receive a recommendation in November. However, we've had to rejig the timescales and pause the options appraisal for a period of time in order for us to re-engage with some new developments that have come up in terms of partnerships with the independent sector, to see how we can provide level 1 and level 2 rehabilitation services across both counties. But also, depending on that, we may need to review our financial work on that as well. So based on that, and to give the ICB and the Trust the opportunity to do that, a revised timeline is provided there, and the oversight scrutiny committees have been informed of the pause. So the ask is for board to note the update, the revised timescales.
Any questions or comments for John? Thank you, John. Duly noted. Should have actually asked for formal approval on the previous section, so my apologies. We're going back a little. Trust strategy. I take it everybody was happy. Lots of thumbs up. Good, good. Just for formalities. Over to estates.
Yes, thank you, Chair. So this is the annual review ring of the estate strategy just board. Clearly, as you see in the paper, we've had opportunity to pick that up in more detail through committee. So just a few things I want to draw out. And again, there's a little bit of just year 4, looking back where we are, and I will just at the end draw out a couple of things which are obviously going to be germane to just the thinking forward and where we're heading with state strategies. But in terms of the current strategy we have, you'll see there's quite a lot of information in there. We've talked a little bit earlier through this board about some of the key projects we've delivered, but if I drew some of that together, one of the large priorities in the last estate strategy was around addressing some of our shortcomings in Redditch, and through the last couple of years, we've actually managed to do that with both the creation of the hub in the town hall, moving services out of what was a very old piece of estate in Redditch, which was Small House. The final part of that here really was the dietary service, which we relocated to a facility, and Small House, which is set out here, we put out to market, and we are close to approaching a sale from April next year, which will be good. That will invest back into estates. That was a key part of it. Other elements of the strategy success, which we've talked about, clearly we've been doing a lot of work down in Herefordshire with the work on Stonebone, which, as I mentioned earlier, is just completing around about now with refurbishment of the first floor, and the MIU over at Princess of Wales, which was if I can just kind of draw slightly forward here in terms of where we are. Clearly, we've still got another year to go on the current strategy, which actually fits quite well with all the contextual environmental changes we've got at the moment. So a couple of bits I did want to call out. We do know that one of the key focuses of future strategy, which we start to draw together, will be around that neighbourhood health part. Still quite a lot of national policy and local thoughts to happen on that. So that will all feature and drive into what it is we think that drives for us. We know we have gaps in quite a few of our mental health hub facilities, particularly. Nice. And it'd be very remiss of me to say that the one large area of estate we've had hanging over for quite some time now is Evesham, and how we address that. At the moment, we're still aiming to hopefully get some sort of SOC, a strategic outline committee review next year to help inform the strategy of what we do. In the meantime, we'll be continuing to try and draw down on critical infrastructure funds, which we know. So some key bits. And the final bit, just to draw in, which we touched on earlier, was just around the estate's utilisation. Piece of work we've carried out over the last 6 months or so, which is now coming to at the point where we're drawing up some principles, discussion with the trust, and then draw up some plans around that. But fundamentally, that's about we have opportunities to better utilise our estate, to drive some productivity, to deliver better patient care, and deliver more for the trust operations. So there's quite a lot there. Just nationally as well, I would just draw out, whilst we're just in receipt of some multi-year capital settlements, the other parts we'll need to access are effectively the strategic allocations of capital. And again, a little bit more guidance to come through over the next several months in terms of how that will work, both with region and with our system partners. And the final piece of the jigsaw is there's an outstanding piece of work which we know will run into summer of next year, which is the national review of how we access additional funding over and above what might be available through the normal public dividend capital. So all of that will come together, and we'll draw that into the work that we've set out here, that we started to do from later next year to inform the strategy. Scott's also just drawn out then the final point I want to draw out. We've clearly got a lot to do in the remaining year, which we'll work through that next year. Next year looks like being a little bit different. We do have a couple of major projects that we need to do, but we also have a focus which we think will be carrying through into next year, which is around how we address some of the probably the larger number of small scale issues that particularly have an impact on our staff as well as the care they can deliver. So we have a capital planning workshop which takes place at the end of November, which will have the format of the plans. So again, that's all I wanted to cover this morning. Greatly to any queries.
Thank you.
So presumably the estate strategy that starts next year is going to also have quite a big net zero focus.
So net zero at the moment, we have, yes, estates is a significant part of net zero. Clearly, it's not new. At the moment, there's 2 strategies, which is nationally directed. I think when we look to draw the strategy together in 27, my preference would be to try and draw 2 together, but nationally at the moment, you need to have 2 different two documents. You have a green plan, which is a 3-year strategy, which is nationally prescribed. State strategy, which clearly isn't everything for net zero. There's a whole load of other things that come to that.
Thanks for that. It's good to see that we are thinking about, how do we utilize our spaces better? Because obviously with the new moving to neighborhoods, there's going to be more about how do we move care close to home. The question is around Evesham, if I may. I know that there isn't any money coming soon, but do we have any contingency plans just in case it deteriorates faster than we think? before we get any funding to replace?
Well, I think there's two parts in that. I suppose the first point is, are we able to maintain Evesham in a safe and appropriate environment to deliver care for our staff? And the answer to that is yes. It is an ageing infrastructure though, and things could fail, which we have a risk on the risk register around. We had some failures last year. There is a separate fund successful to bid into this year, which is the critical infrastructure fund, and we will anticipate getting into that again next year. All that is really doing is keeping the estate safe and ticking over. Clearly, we do need a solution to place Evesham, whatever that might be, but that's quite a long process. So that's something that we last had a good look at before COVID. We produced an outline business case. We actually bid into the new hospital programme, successful. So we're going back round at how we do that. Ellen's been engaged nationally with some of the work, thinking around that. We've got a meeting coming soon as well. So there's a lot going on. I'll let Ellen.
Yeah, I'm not going to talk about it for long, and Robert's mostly covered it. But I have made some contacts, and we have a call coming up, and there are tentatively, I think, potentially some new opportunities around some new financing models that were talked about in the 10-year plan, because Evesham falls in a kind of mid zone. Yeah. It's not really big enough as a cost for the new hospitals programme, the big national programme, but it's too large for kind of piecemeal bits of capital investment. But this kind of middle scale is exactly the sort of thing that would fall into the right range of that programme, I believe. So we're trying to do some networking to get ourselves on the right radar of that. But sort of watch this space, I guess.
Good. Robert, we're seeing the utilisation piece in financial performance in January. Is that
we are, yes.
And hopefully we'll be able to report back to board after that cycle. But it's a really important piece which you touched on earlier. Just touching on Stonebow, where we've invested up to capital, obviously. It's a fantastic facility. Went down there the other day. Many of you have probably already visited recently. I know Ellen did. Fantastic facility. And the meeting rooms up there are great. And I think that we should, wherever possible, if you're going to have meetings or gatherings, committees, possibly even board, I think we should try and get down there. Not least to make sure that our Herefordshire colleagues feel absolutely part of the action, which I know from time to time they don't, but for the record, they most definitely are part of the action. But for us to be down there and perhaps even experience some of their pain when it comes to car parking.
Yes.
Soon.
Well, on that site, there's also a very nice room at Osborne Court, isn't there, Natalie, that we peered into. There was in the courtyard.
Oh, it's a different site. You're to a Stonebow.
Yeah, no, but as another one.
Oh, sorry, yes.
Well, I think we should.
You said.
Away from this, we should definitely do some travelling.
What I'm going to do is, I've just been conscious of obviously the change in our office of the chair and chief executive. So we'll give it as a task to somebody, because we need to have a room that can do this.
Yeah.
Which I don't know actually whether the Stonebow room can. I think it's getting a telly.
It
It got
won't be
telly?
quite so.
Two screens, two cameras. I took a video of it. I took a video to show you.
They were waiting on the big telly.
It's there. It's there. It's up.
I suppose just to be clear about Stonebow development, part of the feedback we got from staff was in Herefordshire, that part was no central place where they could bring teams together. So if they needed to bring teams together for training, or larger team meetings or the like, they had to go out and hire a hotel room.
Yeah.
So we took the opportunity to roll that together.
Yeah,
so
really good.
We're expecting that to be quite heavily used on it.
Absolutely. Good. Right. Thank you. That's the strategic items over. We're into the closing items, so almost there, actually. Almost back on time. Any other business? Does anybody have any other business? Got a couple of items. Firstly, I just want to say to the executives, but also importantly to your SLT colleagues, how grateful I am for the time that they gave me over the course of the last 5-6 weeks to just get under the skin of your areas, your portfolios, your directorates, how it all functions. Lifting the bonnet on some of this stuff is really interesting. And so I'm really grateful for all of their, please convey my thanks to all of them. The dental nurses who were here earlier, I should have said it, it's Dental Nurses Day Saturday. So we should really, again, convey our thanks to them and all the contribution they make and celebrate with them. Excited to celebrate with on Saturday. And my final bit of, my penultimate bit is to say that the chair substantive recruitment process will probably kick off in around January, just so that you're aware. Details TBC, but just to let you know. And at that point also, once that recruitment has been completed, we can set about making sure we've got a full complement of non-exec directors as well. Because sadly, this is Vina's final day, final board day as a non-exec director. So I just wanted to say what a difference we've experienced during your time looking at not least people and culture, but more generally a part of the board, a colleague, a friend, an advisor, a number of other things. The gang in the people director have done an amazing job, but the focus that you brought, I think, has been fantastic. I think sadly you're leaving at exactly the point that I think you're going to take a massive leap forward in so many things. So, you know, policies being done is one thing, but there's so much good stuff about to happen as a result of your input. So very, very grateful for all of that. And I'm sure everybody will say a huge thank you.
Thank you. I mean, it's been an absolute privilege, and you're right. I do feel that we've got to the good bit now, but I'm really proud of how far we've all come, particularly in the people direction, and I'm really confident if we're getting the structure in place, we've got the right people. Onwards and upwards.
All the best to you and yours.
Thank you.
Good. Okay, we I don't think have any sealing and signature of documents, so we'll move on from that. Other than that, sorry, I beg your pardon. Assignment, the one that says on my agenda. That one.
That's the one.
Deed of assignment on St Owen Chambers. Is there anything we need to necessarily comment on that one?
No. It was an ICB property which we are using space to that's effective.
I saw it yesterday and this is very happy.
Yeah.
So you don't have to get out your big red seal.
No.
Good. Signet ring. Okay, good. Excellent. I think the board offers its congratulations to Dr. Alistair Duncan and Dr. Amy Burlingham and also Dr. Farai Makoni for going through the appointments that they've just been through. And then finally, date for the next meeting is the 15th of January next year. I know, it's incredible. It's going to be a while before we meet again formally. I'm sure we'll all see each other again, but just for those that might be on the screen or even members of the public, I hope that everybody has a very joyous time over the next few weeks and up to Christmas. At least have a safe and happy time. Christmas, for those that are celebrating, enjoy the festivities. If you're taking leave, enjoy your leave. But importantly, and my final point is, there are many of our colleagues who will be working over the Christmas period. So I want to formally, on our behalf as a board, thank them for the commitment they're making and working over those days and looking after the patients in the fantastic fashion that they do. So thank you. And thank you to everybody for today.
Yeah, thank you. Huge.
Thanks Fiona and Parth as well, and I think and thank anybody that's watching on the screen, and I think we can conclude the recording there.